But without further ado, as it says here, welcome. I'd like to introduce you to Hormones 101, and I'm going to hand over to our guest speaker, Dr. Carrie Jones. Thank you very much.
Excellent. Okay, can everybody hear me?
Yep.
Fantastic. Okay, so a couple of things. When you're going through my slides, or as you're looking at the slides up there, you'll see that I tend to pack a lot of information onto each slide. And I do that for a couple of reasons. First and foremost, I found as a practitioner that I like to use them as reference materials. And it annoyed me to no end when there would be a list of 10 things, and number 1 would be on one slide, and number 2 would be on 2 slides, and number 3 would be on the 3rd slide. And I just wanted one slide where I could look at all 10 things and then decide from there. So some of the slides are quite jammed, but that's why. The other reason that I tend to put a lot of information on slides is I have found out that my English is a little bit different than your English. And so as I'm talking, you might say to yourself, what did she just say? It's not what we call it. And vice versa. So that way, at least you have it on the slide as your reference, and you can look it up and go, oh, right, she pronounces it that way. That's not how we pronounce it at all, to help you through. As we get going, if you do have questions, what I'll do is I'll leave time at the end of the first session for questions over that part, and we're going to do more treatment stuff in the second part, and of course there will be time for that. And so a little, before we get started, a little bit background about me. Again, I am the person on the slide. I'm Dr. Carrie Jones. I'm a naturopathic physician from the United States. I live in Portland, Oregon. I am the medical director for Precision Analytical, which are the makers of the Dutch test. I've been in practice about 12, 13 years, and women's health and hormones is all I do. I did it in medical school. I did it in my residency. I was the medical director of three now, two large integrative clinics in Portland. And by integrative, I mean there were naturopaths, there were GPs, there were physician's assistants, nurse practitioners, acupuncturists, what have you. And so I have a lot of experience with integrating hormones, if you can prescribe them, or if they come in on hormones, or how do we take it from the nutrient, the diet, and the herbal approach. And I also apologize to, in the States, we don't say herbs, we say herbs. So I'll slip back and forth. I'm trying to call it herbs because I know it sounds dumb to you guys. And the other one, when I was in Australia last year, lecturing, one of the Australian lecturers said, those Americans, they do whatever they want. They take the O off of estrogen. So I apologize, my estrogens do have, all the word estrogen has the O taken off, but I think the O off of estrogen is really quite the least of our concerns in America right now. So, all right, advanced cases and clinical pearls to understanding hormones, adrenals, and the Dutch test. This is obviously a very specific Dutch-related lecture. However, a lot of the protocols can be used widely, depending, if you're doing serum or other ways for measuring hormones, or if you just have a woman who's having hormonal issues and you need some reference material on where should you go, what should you test, what supplements, what treatments, what diet should you be looking at? Disclosure I've already said. All right, these are the objectives. So what we're going to do is we're going to do a brief review of the hypothalamic pituitary adrenal axis. We're also going to do the same for the ovarian axis. We're going to review a Dutch complete from top to bottom, basically to make sure that we're all on the same page. We're going to talk about our new marker, the 8-hydroxy-2-deoxyguanosine, which is a oxidative stress DNA damage marker. We're going to talk about estrogen metabolism, which is hugely important for men and women. This talk is 100% about women, but you can apply a lot of it to men as well when it comes to estrogen metabolism. Estrogen dominance in women, PMS, tender breasts, weight gain, those sort of things, and then of course cancer risk. While men don't necessarily get all of those symptoms, they still can have the same cancer risk, and men with estrogen tend to get the man boob development, and the weight gain around the middle, and they get depressed and they get moody, and estrogen, we have to clear their estrogen out as well. We're going to discuss some cases, Dutch-related cases, and what you can do. We're going to talk about treatment ideas. We're going to review androgens, DHEA, and testosterone, because a lot of people forget the androgens are made both in the ovary and in the adrenal gland. And so as a result, we're going to talk about one of my PCOS cases to help you differentiate between insulin-based PCOS and non-insulin-based PCOS. They're different. And then lastly, we're going to follow up with this, just treatment in general and go through the summary. So let's talk about the HPA axis. Again, this is just to make sure we're all on the absolute same page before we roll right into Dutch. So the stress definition, stress is a state in which homeostasis is actually threatened or perceived to be from. And there's so many things that can cause stress in our life now, right? Emotional, physical, psychological, environmental, chemical. I mean, it's just all around us. And here's the kicker. Stress is actual, anticipated, or imagined. And this is what I mean by that. This is a true story. So actual stress. In April, my best friend and I, we both work at the Dutch lab together. We were flying to a conference in Hawaii, and from Portland, Oregon to Hawaii, it's about a 5-hour flight. The captain came on and he was like, ladies and gentlemen, we are on the heels of a super, super bad thunderstorm that's rolling right into Hawaii, and we're probably going to catch it before it moves on the other side of the island. So if you are scared of flying and you need to take something, now is the time. My friend who hates flying, had her like anti-anxiety medication with her. And man, I've never seen that bottle ripped open so fast, and she was down in it like no other. That's actual stress. Her HPA axis shot off immediately. Anticipated stress are with if the captain came on and said, ladies and gentlemen, we're on the heels of a storm heading into Hawaii. I don't think we're going to have any issue. I don't think there will be any turbulence, but I am going to ask you to just sit in your seats and relax, and I think everything's going to be okay. Certain people will still anticipate that. It hasn't happened. The turbulence isn't there. The captain didn't panic. It doesn't matter. They react the exact same way, and their HPA axis ticks off. Lastly is imagined stress. Now, imagined stress people are people who make mountains out of molehills. This is my mother. These are your worst case scenario folks. This is the person who's on the plane and the captain says, ladies and gentlemen, it is a beautiful day in Hawaii. There are no clouds in the sky. Just sit back, relax, enjoy your flight, have a drink. We'll be there in 5 hours. It doesn't matter if you're scared of flying, you're scared of flying. You're in the air, you're hurtling through space in this tin can, you don't understand aerodynamics, you're going to crash because that's what happens. Your HPA axis kicks off. It's the same. So if you live your life in imagined stress, or you have that client or patient that lives their life in anticipated or imagined stress, they will always have an HPA axis cascade. It doesn't matter if it's the chemical is there or not. It doesn't matter if the gluten is in their diet or not. It's an emotional thing or not. It's how they respond. The other really bad thing is stress is cumulative. This is why we always say, how come I can go out when I'm young and I can stay out all night and I can hang and I can party and then I can get up the next day and go to brunch and it's no issue? And now that you're older, you're like, I'm in bed by 9. Are you crazy? I'm not going out. It's because over time, this is my analogy, it's like a trampoline. You bounce off your HPA axis over and over and over again, and after a while, those fibers get really thin, and you bounce and you hit the floor, and you don't bounce up as high as you used to. If you haven't been taking good care of yourself, if you haven't been dealing with your stress appropriately and taking proper downtime, then it's going to become cumulative over time, and you'll get this down regulation in your HPA axis, and a down regulation in your parasympathetic, which of course is your calming, your relaxed part of your sympathetic or of your HPA axis. So we're going to go back to the basics just as a reminder. Where does cortisol come from? What are the hormones you're really actually dealing with, and how long do they hang around? So we have the fasciculata. This is in the cortex. This makes cortisol. Cortisol is not stored for immediate release. It takes about 10 minutes for it to kick off. So when you get in that fight or flight state, I learned today, we call it norepinephrine and epinephrine. Apparently you guys call it adrenaline and noradrenaline. So it's norepi and epi that kick off. Cortisol takes about 10 minutes to release, and then it takes 1 to 2 hours to break down. So if you're having liver issues, you may have a person that has circulating cortisol for a while because they can't break it down. Because so instead of going 1 to 2 hours, maybe it's 3 to 4 hours. Maybe it's all day. And the same is for norepi and epi when we get to that slide. Cortisol is bound up by cortisol binding globulin, otherwise known as transcordin. And this binding globulin is very sensitive to estrogen, just like your other binding globulins, such as thyroid binding globulin, sex hormone binding globulin. So if you have an estrogen dominant woman or a woman on the birth control pill where she has all that excess estrogen, there's a real good chance her free cortisol might be low because it's all bound up. It's all stuck to this binding globulin. And so as you know, binding globulins are like little buses. They drive through the system. And then when they get to where they need to be, they open the door, and the free cortisol can now get off and be free and active. Hormones are like children. You can't leave them unattended at any time. And so that balance of binding hormone is really, really important. And then lastly, free cortisol is only about 5%. So when you're looking at the Dutch test specifically, we give you free cortisol and free cortisone. Keep in mind that's only the 5% or less that's floating around. It's very similar to total testosterone and free testosterone, or total T4 and free T4. You're looking at the teeny tiny amount that's allowed to be released and do something compared to how much is made in total. So it's a very small amount. Again, hormones are like children. Your body does not want them running rampant. You don't want them running rampant. You know what the symptoms are. We have the glomerulosa. We're not going to talk about this today, but this is aldosterone. This is your salt-water balance. For those of you who are doing, when it comes to adrenal issues, if you're encouraging your patients to do more sodium or salt, and they're having a negative response, it's usually in this system, the aldosterone system. So, but we're not actually going to have time to talk about that, but just keep that in mind. Next, we get to the reticularis. So these are your sex hormones, and this is really, really important to know because DHEAS, 100% of DHEAS in women and in men are made in the adrenal glands. Now, DHEAS is the sulfated form. It's not the active form. DHEA is the active form. So when the body makes DHEA, it immediately, usually, converts it over to DHEAS, and then when it needs DHEA to do something, it takes the S off and pushes it further down the steroid pathway. So you all have steroid pathways, or if you didn't, definitely grab them on the break. They were out on the table, or I'm sure you've gotten them from Regenerus before. If you follow the steroid pathway, DHEAS doesn't go anywhere. It's just DHEAS. You needed the S off to move downstream. And for those of you who are into genetics, it's the gene is the SULT, S-U-L-T, SULT2A1 gene that plays quite heavily here. 80% of DHEA is made in the adrenals. The other 20% are made in the ovaries. 50% of the androstenedione are made in the adrenals. And 25% of the testosterone are made in the adrenals. We'll find out later, but just as a heads up, 25% of your testosterone are made in your ovaries and 50% are made in your fat tissue. Now, unfortunately, the more fat tissue a woman has on her doesn't mean the higher her testosterone necessarily. But when we get to the PCOS case, we'll talk about the insulin-based versus the non-insulin-based for those who do have really high testosterone. Or if you have a menopausal woman who has experiencing low testosterone and subsequently low sex drive, you want to support the ovaries just as much as you want to support her adrenal glands to help get that back. In men, all the DHEAS, 80% of the DHEA, and then less than 10% of the androstenedione, and less than 5% of the testosterone, because of course their stuff is made in the gonads. All right, now we have the medulla. This makes your noradrenaline or adrenaline, norepi or your epi. It does come from tyrosine, so if you're trying to get somebody's norepinephrine and epinephrine up, you can do tyrosine-based foods, or you can actually supplement with tyrosine. Or you can use phenylalanine. I do like I personally, I don't know if you guys, can you guys get phenylalanine? DLPA is what it's called, DL-phenylalanine. Well, if you go to the States or Canada, you can load up. So phenylalanine helps release endorphins. So in the States, I'll use the supplement phenylalanine because for especially your fibromyalgia patients who are in a lot of pain, that can be really quite helpful. And it doesn't have quite the stimulatory effects that I see from tyrosine. And for those who have very low norepi and epi. But as I said before, these catecholamines are pre-stored. So if you're about to get in an accident, if you're about to slip and fall, if you're about to drop your cell phone like I almost did earlier and you get that panic fight or flight moment, like, no, don't break the screen, it's those two that release immediately. Now, thankfully, you can recover quite quickly. The half-life is just a few minutes, except if you have an MAO or a COMT or COMT issue, then you're not going to break down your norepi and epi very quickly, and you may have the client that has that anxious, jittery, can't sleep feeling all day. One of my very best friends would say all the time before we did her genetics, when I get stressed out, I can't come down from it. It lasts all day. And now we know she actually has both MAO and the COMT gene, that she can't break it down effectively. So a teeny tiny bit of adrenaline gets released, and it just goes and goes and goes and goes in her poor system. So the fight or flight response, really what is it? It's when stress occurs and the HPA axis runs to the adrenals, instead of going to the neocortex for logical processing, and the end result is total freak out. And we know this because I'm sure many of you have had the incident where you, like, something not so stressful happens, but yet you're completely freaking out on the inside, and you're like your other body that floats above you was like, why are you freaking out? And you're like, I have no idea. I don't know. I can't stop. So in your head, you're like, this is not a big deal. This is not a big deal. This is not a big deal. Why am I freaking out? It's because your actual HPA axis and your neocortex are at odds with each other. They're not communicating. And it's by design, because by design, you're supposed to be running from things that are bigger and scarier, with big teeth and big paws that can kill you. But we don't have that anymore. Right now we have bills, and we have environmental toxicants, and we have political turmoil, and we have all this other stuff that's not necessarily like going to kill you like a saber-toothed tiger, but it does cause problems in your life. So we want that immediate HPA release back then, and now I wish biology would catch up to the 21st century. One of the things I say all the time is that when it's my turn, I'm going to be one of the goddesses of the universe. Not the goddess, just one of them. And I have some changes to make in the human body, and this is one of them. All right, so the simplified stress response, what happens? Stress happens, any kind of stress. Inflammation, infection, emotional stress, your day sucks, you got a bad phone call, you're late on a bill, it doesn't matter, you're sick. All of this goes to the brain. The brain then goes down, so the hypothalamus tells the pituitary, and the pituitary says to the adrenal, okay, adrenals, make cortisol, make adrenaline, make noradrenaline, and help this person combat the day. It's a protective survival mechanism, and we definitely need it sometimes, but the problem nowadays in the 21st century is that we get it way too much. So this is the simplified response. Long term, as we know, things start to shut down. You get a shutdown in the parasympathetic nervous system and an upregulation of the sympathetic. It's like a switch gets turned on and they're chronically in fight or flight. And as a result, they get this issue with epi, and cortisol production. It starts to fail, or you get receptor sensitivity. The receptors are like, stop touching me, and they go back inside the cell. It's like, I liken it to little annoying kids who are constantly tugging on you. Like, so if the little annoying kid is cortisol and you're the receptor, and they're like, mom, 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 mom. Right after a while, you're like, oh my God. The receptor does the same thing, and it pulls itself back inside the cell, and it goes and takes a bath, and it shuts the door, and it pours itself a glass of wine, and it completely ignores cortisol or adrenaline. And then those things just circulate, and now they just build up in your body. So your production might go down, but your free availability goes up because the receptor is not having it, just like an annoyed parent. The problem is the symptoms progress, though. We get all these digestive issues, we get hormonal issues, we get insomnia, we get libido problems, we get anxiety and mood issues, we get cardiovascular issues, we have erectile dysfunction and fertility issues. So there are a lot of things, our patients come into us and it seems unrelated. You know, they come in and they say, I have gas and bloating all the time, I can't figure it out. Or I have really bad hot flashes, but only when I have, certain events happen, only when I'm really stressed out. Or I didn't have any hot flashes, but lately they've come back and it turns out they've had a really stressful week or a stressful weekend or a stressful event has just happened. And it's very much related. Sex drive, right? If you are completely stressed out, the body is like, yeah, I'm not in the mood. This is not going to happen. But patients still come in and they're like, I'm so tired and I'm stressed and I have high anxiety and I can't sleep. Oh, and I have no sex drive. I'm like, yeah, no shit. Like, I wouldn't either. If everything's a 10 out of 10, like, what do you, like procreation is what the body's all about right now. So it definitely is a big circle and everything absolutely is connected. This is one of my favorite books. It's called Power Up Your Brain. I don't know how many of you have read it. It's written by David Perlmutter, who of course everybody knows and adores, and then Alberto Villoldo, who is a PhD shaman. So they wrote this together, and it's all about brain function from both a really scientific and really esoteric point of view, and it's really good. I highlighted like the whole thing. But this is one of my most favorite quotes. Chronic stress can lead to a rut in which the wiring of our neural networks keeps us repeating the same dysfunctional behavior and hoping for a different outcome. What is this essentially the definition of? Insanity, madness, right? Absolutely. But what we forget is that chronic stress is anything. It's what we tell ourselves. It's what we eat. It's what we get exposed to. And it's called neuroplasticity. It's where the brain lays down the same path and it gets reinforced over and over and over again. And it's a hard pattern to break. If somebody's eating gluten every day and they shouldn't be and they can't figure out, well, they're not getting better, it's like, well, the brain doesn't like it, and it's telling the rest of the body it doesn't like it. So your digestive tract doesn't like it, your skin doesn't like it, your emotions don't like it, like nothing likes it, but that's what you keep reinforcing. It's the person who tells themselves negative things. I'm not good enough, I'm not pretty enough, oh my gosh, I'm too fat. It doesn't matter, as long as you keep supporting that same neural network, that's the reality, and this is why. So I liken it to those fields where you see a field of grass and that people have walked the same path over and over again, and so it's all worn down. It's the same in the body. You walk the same path in your brain over and over again with this plasticity, and so you just reinforce the same network. And I say to patients, hey, you know what? It's going to take a while to get you off that path, get the grass to grow again, and move you over to this more healthy path over here that's happier and gluten-free, and get that pathway worn down. It's not an overnight happen, but it can happen. It just takes time. So just remember, this is what's happening in your patients for real. All right, to sum up, so if it all starts with the brain's decision to kick off this cascade, and the hypothalamus tells the pituitary to tell the adrenal to make cortisol, and you have adrenaline and you have noradrenaline, and that's pre-stored and everything's dumping at the request of the brain, why do we keep blaming the adrenals? Why do we keep going back to say, oh, it must be adrenal fatigue, those poor adrenals, they're so dumb, they're so bad, your adrenals are failing you? Just be really careful, because we know it's super multifunctional. We know it's super multi-system. So I believe the symptoms are absolutely real, adrenal fatigue, quote unquote. I absolutely believe it. But the actual definition, or the actual title, I'm like, well, it's a lot more involved than that. Because it's the brain's decision, and the brain is taking in this huge amount of processed information to decide whether or not you're going to get cortisol, epinephrine, or norepinephrine. So just keep that in mind when you're treating patients. You don't just microscopically focus right on those little glands right above the kidney. Go global, and you'll actually help better and faster and deeper. So let's just review real quick, since we're going to just keep talking about cortisol and we get into treatment especially. What does cortisol do? Its primary absolute job is blood sugar balance. That's what it does. Gluconeogenesis and glycogenolysis, that's how it works. It's called a glucocorticosteroid for a reason. Glucose because it manages glucose, obviously. Cortico because it's made in the cortex of the adrenals, and steroid because it's a steroid hormone. So if you have a patient or yourself sitting in the audience and your blood sugar and insulin are not very well regulated, you are causing a lot of stress on your body, on your HPA axis. So keep that in mind. A question I get asked a lot in other conferences and lectures is, what do I feel about intermittent fasting? Which you probably get that question from patients, or maybe you've been reading it, maybe you do it yourself. I'm okay with intermittent fasting as long as they have a robust HPA axis. If you tell somebody who has a really crappy HPA axis, hey, now I don't want you to eat for 16 to 20 hours, see what happens. They're going to hate you, because it's cortisol's job to deal with blood sugar dysregulation, and you've just told them not to eat, but they can't handle the not eating part. They can't physically pull themselves up. So support the HPA axis for a while, and then have them gradually move into intermittent fasting if that's what's for them. The wake-sleep center, of course, we know cortisol's high in the morning to get your butt out of bed. It follows the sun. If you guys had sun here. Which I joked, I did a lecture last night. So I'm from Portland, in Portland, Seattle, but we're not much better. And our joke all the time is that we get sunshine in Portland, Oregon from about July 5th to about July 6th, and that's it. Like, that's the summer in the Pacific Northwest. Not much vitamin D exposure either, maybe like you guys as well. But cortisol's supposed to be high in the morning with sun, and then it goes down at night, and that's when melatonin comes out, so melatonin follows the moon. Cortisol can be quite the bully, though, if you don't know this. So if your cortisol's high at night, it can suppress melatonin production and subsequently suppress growth hormone production. And if you don't make enough growth hormone, then you are at risk for not getting that healthy restorative sleep. So if you don't wake up feeling like $1 million, well, your bucks, pound, $1 million pounds, then it could be a growth hormone issue. So keep that in mind. Lastly, it's anti-inflammatory to a point. This is amazing. Cortisol goes up to help you fight infection, viruses, bacteria, whatever. It does influence the innate and the acquired immunity. It can influence the Th1, Th2 switch, so be careful. Pro-inflammatory cytokines stimulate the stress system. When you have pro-inflammatory cytokines happen, the HPA axis goes and sends cortisol out to help combat it. And the last thing I just learned earlier this year, there's a great PhD immunologist in the States. Her name is Heather Zawicki. She was my immunologist in medical school, and I attended an autoimmune conference. So what happens is, she says the morning spike in cortisol is what triggers the cells in the thymus who fail central tolerance to get destroyed. What does that mean? So your body makes immune cells, and before it gets let out into your body, so before, like, let's pretend you guys are all immune cells. And before you're allowed out that door in the body, your thymus will check each and every one of you to see if you're already autoimmune. And if you are already autoimmune, then you get pushed off to the side, and the rest of you can go. And then it kills you. You die. What does that, what triggers that, is that morning spike in cortisol. So if you have a flatlined patient, or a patient who doesn't have a very robust cortisol spike, then those autoimmune cells over there will accidentally get let out also. And it can worsen autoimmune flares, or it can bring on autoimmune conditions. Obviously, a lot goes into autoimmunity, but when she said this, I was like, son of a gun. Really? Cortisol? Come on. And we know that this probably happens often because there's so much autoimmunity, and those who have autoimmune often have multiple flares. And so this is just one of the pieces of the pie that you can look at and go, what is their morning cortisol spike? DHEA. DHEA, of course, being the other big adrenal hormone, it does function as an anabolic counter-regulatory hormone to cortisol. Anabolic, of course, meaning building, like testosterone, the more male-related hormone. Cortisol is catabolic. It breaks things down. It is a weak partial agonist at the androgen receptor, so very weakly can it turn on the androgen receptor, which for those of you who can get or have seen or have used DHEA, if somebody takes too much DHEA, it can really sometimes induce things like acne and facial hair and greasy skin and greasy hair, anger and irritation. And I found this out the hard way. I was saying this at a lecture last night. I was in an integrative clinic, and the MD I was working with was new to functional medicine. So she was constantly picking my brain and doing all this research, and she'd heard or maybe seen on YouTube, which is how she learned. She would watch a 5-minute YouTube video, and suddenly she was the expert. It would go on our website. It was awesome. So she heard DHEA helped with energy. So this patient of mine couldn't get in to see me, saw the MD and said, I'm so tired. And the MD said, great, I'm going to put you on DHEA. And unfortunately, there's a woman-sized dose and there's a man-sized dose. So the woman-sized dose is quite small, 5 to 10 milligrams. The man-sized dose is quite larger, 25 to 50 to 100 milligrams, depending on the man. So essentially, she put the patient on DHEA. A week later, she's in my office. She got in to see me, and she's irate, super mad, and she's banging on the table as she's talking to me, and she's angry all the time, and her face is broken out, and her hair is greasy, and she can't figure it out. And so I'm looking at her chart, and I'm like, when did you go on DHEA? And she has the bottle in her bag, and she slams it on the table, and she's like, the other doctor put me on it last week for energy. This is what she gave me. And unfortunately, she was on about 60 milligrams of DHEA, so 6 to 7 times more than she should have been as a woman. And I was like, oh, this is why. So we had to take her off the DHEA. She was not thrilled that she was given the wrong dose, but it just goes to show DHEA can really rev up those androgen receptors, and it's very dose dependent. You have to be careful. With the Dutch test, though, you can see when we get to this page, if they're an alpha person, if they have high 5-alpha reductase, they're more likely to get the negative side effects when you try to support testosterone or DHEA. If they're a beta person, which we'll talk about, then they're less likely to get the side effects. Thankfully, this person happened to be an alpha person. Actually, it fit her personality. She was a mom of 5 boys, a single mom of 5 boys. So she was very alpha, very in charge. And it was really funny because I was like, well, you you are an alpha person all the way around. So DHEA is made in the brain. It's made to protect against the damaging effects of cortisol. That's great. We don't want cortisol to damage in the brain. One of the primary places it damages is the hippocampus. I'm sure many of you have had stressful events and all of a sudden you've lost your short-term memory. It's cortisol's effect on the hippocampus, and you want that DHEA to go up to protect you. All right, so back to my question, does adrenal fatigue in its title exist? Well, my most favorite little meme in the whole world, suspicious cat is kind of suspicious. And again, I really like that all of the attention it has brought to the HPA access, and I really appreciate, when we talk about different treatments for adrenals. However, I do think it needs a new title because I feel everybody has taken the Facebook quiz, could you have adrenal fatigue? And are you fatigued? Why, yes, I am. And all of a sudden, that's what they have. So just keep a macroscopic view, look big, don't focus right in on the adrenals. Look at infection, look at the gut, look at the brain, look all over is all I'm asking. When it comes to to testing, there are a lot of questions that you want to have answered, which is why many of you are using the Dutch test. So first and foremost, you want to know, can you even make cortisol in the first place? Because if you can't make it, then you're not going to have any floating around, and you need to do something about that. Next, you want to know how much of it's free and active, because only the active part, the free cortisol, is what can actually bind to receptors and do stuff. So the free is what you need. And then what is the pattern? Do you make enough cortisol, but you just make it at the wrong times of day? Maybe you're too high in the morning and too low at night. Maybe you're too low in the morning and too high at night. Maybe you flatline all day. Maybe you're high all day. I don't know. So that's why you want to test and find out what your circadian rhythm look like. So what if our hormones are a mess too? All right, let's switch into hormones. Let's talk about all the stages just so we have the same terminology, because I'm sure it's the same. I haven't heard otherwise. But just to review, so perimenopausal women, these are your typical cycling women. These are the women who still are supposed to get a cycle every month, regular as usual. I meant pre, of course. Premenopausal women, cycling women. The next stage are your perimenopausal women. These are the women that are moving into menopause. Things are kind of going crazy. Her ovaries are sort of deciding to shut down or not shut down. They're not sure. She's skipping cycles some months. She's having hot flashes some months. She's having some issues some months. And then other months are perfect and she can't figure it out. Menopause is when she's in that 12-month stage of no menstrual cycle. So suddenly she doesn't get a menstrual cycle and it never comes back. Menopause. Postmenopausal, the classic definition of a postmenopausal woman is she's had 12 full months of no menstrual cycle. When she's beyond that, she's postmenopausal. If you don't know what that looks like, this is what it looks like. Each individual blue line that goes up and down, and those are 6 months of a normal cycle. So there's 1, 2, 3, 4, 5, 6, falling roughly every 26 to 30 days. Very normal. This is what we like to see. This is menopause. Along the very, very bottom are red and blue line. You can hardly make them out. That's estrogen and progesterone because they're supposed to be very low. She's menopausal. And the red and blue line that you can see that are higher through the middle, that's LH and FSH yelling at the ovary, telling them to do something. And the ovary says, no, I'm not doing this. We're not making estrogen and progesterone anymore. Perimenopause looks like that. It's kind of mad chaos. It depends on the month. It depends on the week. Heck, it depends on the day. It definitely is all over the board because, again, the brain is trying to communicate to the ovary. The ovary is trying to decide if it's done or not, and it's not a very smooth ride. This is your normal menstrual cycle, as y'all know. So we have the first part, which is your follicular phase, your second part, which is your luteal phase. Remember, progesterone only comes out once she ovulates. If she doesn't ovulate, she doesn't make progesterone. That's why you see the high rise in progesterone in the second half, and that's why we test in the second half. Common concerns are the things that walk into your clinic all the time. These are your luteal phase defect. This is your PMS, your PCOS, your fertility, your libido, your hot flashes, your weight gain. This is your cognition, your bone. These are your classic female symptoms. So when do you test? Well, if she still has a normal regular cycle, you want to test her on day 19, 20, or 21. which is basically 5 to 7 days after she ovulates. Now, if she has long or short cycles, you just adjust. If she has 60-day cycles, they're every 60 days, you just shift up. And if she has short cycles, she gets her menses every 24 days, you just shift down when it comes to collection, if she's regular about that. If she has irregular cycles, some days she's 60, some days she's 28, some days she's 15, then she's 45, you can try to do the LH kits or the ovulation predictor kits. You can try to have her track her ovulation symptoms and see if she knows she ovulates. Then you count forward 5 to 7 days and you collect. If it's complete mad chaos, she doesn't ovulate, you have no idea what's going on, then guess and hope for the best, unfortunately. And sometimes, honestly, I won't test hormones if it's just mad chaos. It's not worth it because it's going to change the next day anyway. I'll test other things, thyroid hormone, adrenal hormone, GI hormone, brain hormone, just depending on the person. But I won't necessarily go, okay, estrogen, progesterone, I have to dial in on those because it's all over the board. If she doesn't get a menstrual cycle at all, she's completely, like, let's say she's 28 years old and has no cycle, and you don't know why, like she's not on the birth control pill, normal things that might suppress it. In that instance, honestly, I often don't test hormones either because I'm working to try to get her cycle back. If she hasn't had a cycle, I know her estrogen and progesterone are going to be low. So I save her money and I test other stuff. I look at all the things I mentioned, thyroid, adrenal, organic acids, nutrient. Like I go that direction instead and try to get her cycle back, give me something to work with so then I can test. Now I may also look at other things, FSH, AMH, anti-Mullerian hormone. I may look at like reasons, maybe she's in premature ovarian failure, early menopause, but I don't necessarily go right for the hormones. That's just me. A lot of other practitioners think differently. Just food for thought. All right, what does estrogen do? Turns out it's really pretty important. It's not always the bad guy, for sure. So it's mostly made in the ovaries. A small amount is made in the adrenals. And even in menopause, a small amount is made in the ovaries. And it can aromatize from testosterone. Women can absolutely aromatize. We think of it with men a whole lot more, but women can do the same thing. Obviously, it helps with growth and development. It does help greatly for fertility. So if you have a woman with too little estrogen, estrogen tells the progesterone receptors to come out in the uterus. We want that. We want thick, fluffy, healthy uterus lining for implantation to occur. It's really important for bone health. We know low estrogen can increase the risk for osteoporosis and osteopenia. It's really important for the brain, for cognition, for temperature regulation, for all the things that we know go to hell when it comes to menopause. Estrogen helps with those things. It's great for collagen. We know when estrogen goes down, women say, I feel like I have more wrinkles. I feel like my skin is thinner, more tissue paper-like. It's the loss of estrogen causing the loss of collagen. It's really great to protect against atherosclerosis, cardiovascular disease. And I already said with estrogen does help with progesterone for fertility. Why does it decrease? There's a whole list here. So again, I've packed a lot onto the slide, but I just want a reference slide where you guys can go, why is this person's estrogen so low? And you can go down all these different rabbit holes and try to figure it out. Obviously, age is number one. If she's 55 or 60 or even in her 40s, it's probably a menopausal thing. Irregular cycles, if she's got irregular cycles or she's skipping cycles, estrogen's probably going to be low because of that. Anorexia is a big one. Low cholesterol, be careful because with low cholesterol, you don't make hormones, right? Cholesterol is the backbone to all hormones. And I've definitely had women, men also, who are put on medications to suppress cholesterol, and now their hormones are really, really low. And so I'm calling their GP saying, hey, I think you have them on too much cholesterol medication because it's so low, now they can't even make hormone. So definitely check into that. And I actually had that. I had a guy who was on this super high medication dose to suppress his cholesterol, and he had like next to no testosterone, next to no DHEA. I mean, it was just awful. And of course, he felt awful, but he had low cholesterol. That's all he cared about. Extreme exercise or training. I was saying this last night. Those CrossFit is huge in the States, and apparently it's huge across the world, and people get very addicted to their CrossFit, but they get addicted to a lot of these things like what are those, like those races, you know, those 3 or 5 or 10 mile extreme races where you jump fire and climb under barbed wire and do all this stuff, and then they train for it. It's so big. Marathon runners. I had a patient, she ran a marathon every weekend, and she couldn't figure out why she wasn't getting pregnant. Are you kidding? Every weekend she ran a marathon. And so if you're constantly running, then the body's like, there must be a tiger behind me. Why am I going to stop and get pregnant? So once she stopped running marathons, like the fall season hit, when the fall season hits, I'll stop running marathons. I'm like, all right, fine. So we waited the fall season, and by Christmas she was pregnant. But just pay attention to those patients. Ask them how often they're exercising and what they do. It's pretty interesting. Obviously, extreme stress. A lot of women have probably experienced extreme stress where it threw off their cycle. Sometimes even women who fly across the world or change a lot of time zones, their cycle will get all thrown off. Under appropriate body weight. So there's a lot of different research on this, but it's kind of agreed like under 15% is when amenorrhea starts to happen. And actually, on the train up here, I had a practitioner that I was consulting with, and on the requisition form, they checked that they were underweight and their hormones were very, very low. So I emailed the practitioner and said, are they underweight because some people are just naturally thin, or are they underweight because there's a problem? And he wrote back and said, I think she has anorexia. She's like 13% body fat or less. And I was like, well, there you go. That's probably why. She doesn't have, the body is like, we're starved. There's nothing on me to make hormone, and so I can't. Hypogonadism, this is when the ovaries fail, also known as premature ovarian failure. Hypopituitarism, this is the brain issues, brain that is not communicating. This can happen for a myriad of reasons. Think of like traumatic brain injury, car accidents, military, sports incidences where you hit your head. American football, we hear about this all the time. They get hit over and over and over again in the head, and then they have all sorts of hormonal problems afterwards. And I know this because a lot of practitioners run our test, the Dutch test, on sports athletes in the States. And so I'm like, wow, that is bad. And it's a real problem. And so if the brain can't communicate with the ovary, then it's not going to make hormone. Blood flow. If you have decreased blood flow, think surgery. If she's had endometriosis surgery, if she had any kind of abdominal surgery, if she had a cyst removed or a polyp removed or a fibroid removed, anything that decreases blood flow in that area, surgery's really precise. It's still done by a human, and capillaries are really tiny. You guys don't pronounce it capillaries, do you? Yeah. Really tiny. And so other things that gum up the works, think your diabetics and think your smokers. They tend to go into menopause sooner because all the junk in cigarettes and all the sugar from diabetes clogs those, teeny tiny little capillaries. Breastfeeding, obviously, hypothyroidism, obviously, PCOS, fertility medications, opioid pain medications will suppress, and of course, a lot of birth control pills are birth control things that are hormonal, the pill, the patch, the ring, the implant, and the injection, because they're trying not to get them pregnant. It is amazing, though, the number of practitioners who call me and say, Carrie, their estrogen's really low. I'm like, I know, they're on the birth control pill. So make sure you ask her, and a lot of clients think of the pill is something they do every day. They don't even think about it. So when you ask them, are you on any medications? They're like, no, I don't take medications. But they're thinking like an antibiotic or, something like a medication that got prescribed to them and it's short term. And then like, are you on the pill? Well, yeah. That's okay. Yep, we got to write that down. All right, why do they increase? A lot of things overlap here. Overweight and obesity, fat tissue can make estrogen, which is one of the things I will change when I'm a goddess of the universe. Diabetes, PCOS, again, why PCOS? Because it could be either or. With PCOS, it can be due to weight and insulin, or it can be due to the fact that her cycles are non-existent, and so she has low estrogen. So you can get both high estrogen and low with PCOS. If she's on estrogen, obviously, steroid medications, so if she's on some sort of prednisone or synthetic cortisol for some reason. Liver issues, dysbiosis, over-aromatization from testosterone. Over-aromatization typically happens due to excess inflammation and due to excess blood sugar. So if she's highly inflamed or her blood sugar is not controlled, same for men. Men get the increased testosterone to estrogen conversion by the same two things. And the more fat tissue a person has, oftentimes the more aromatization they have. Male or female, it doesn't matter. Environmental estrogens, we can't test for them, but if the exposure is there, you suspect it, they tell you in their history where they grew up, the things they do. Definitely work to cut that out. One of the things I was raised in the South, and my parents still live there, and my mom, bless her heart, still uses the plastic cling wrap and microwaves it for her food, and I'm like, mother. She's still to this day, and so she's just not going to stop. And so, but if you hear these things, or if you hear that, they grew up in an area, they do a particular job, right? People come to you and they're in a very toxic job, mechanics, or, people who work on cars as hobbies. People are into crafts and use certain paints that, that could be a lot of exposure. Alcohol, unfortunately, the fun things in life really screw up our hormones. So 2 or more glasses of alcohol a day has been shown to raise estrogen. It just backs up the liver and it just recirculates. And then ovarian cysts, of course. We all know the common symptoms of high and low estrogen, so I'm not going to go into those. Everybody knows those. So progesterone. So as I said earlier, progesterone is made in the ovaries from the corpus luteum. Tiny amount is made at menopause. That's what sort of keeps the woman afloat. In dried and 24-hour urine, so in the Dutch test and in 24-hour urine testing, we look at the 2 metabolites, the alpha and the beta, the A-pregnanidyl and the B-pregnanidyl. We do this because the A-pregnanidyl is what helps with anxiety and insomnia. So when you have a woman who is losing her progesterone and she says, I have a lot more anxiety lately. I all of a sudden can't sleep. I hear this a lot as women transition into menopause. They used to sleep like a rock star and now they can't anymore. Their alpha-pregnanidyl is going down, so they're not getting that support for GABA. It's the alpha that goes up to GABA and stimulates it. Really important. Now we can fake it. We can give them GABA derivatives, or you can use GABA itself. It's not supposed to cross the blood-brain barrier, but because it's a big molecule, but in some people it does. Or people will give pregnenolone and you can give progesterone because these things turn into alpha metabolites and subsequently can help with sleep and anxiety. So what does progesterone do? Well, it does a whole lot of really awesome things. I tell my patients it's the happy, calming, everything's going to be okay hormone. And they're like, yeah, I want that. That's what I want right there. So it does, as we talked about, it helps with anxiety. It does help, it's an antagonist to mineralocorticoid receptors, so it does help combat bloating, but too much progesterone can actually induce water retention. So you have to be really careful. It's a fine balance. It does prepare the uterus for implantation. When pregnant, it decreases the maternal immune system. This is really helpful so that the mom's immune system doesn't go in and kill the foreign thing growing in her uterus. The neurosteroid aloe does help with sex drive. So again, aloe is what I talked about in the prior slide. It's the progesterone that is able to cross the blood-brain barrier. The aloe is what it turns into, A-L-L-O. It supports neurons in the brain. So for those, and the next line, it's often given at high doses immediately after traumatic brain injury or stroke to protect the brain. So they'll do IV high doses of progesterone to help. It does enhance serotonin, which we're going to talk about. It does reduce and relax smooth muscles, especially in the lungs, which is great. It does reduce gallbladder activity because we know high estrogen does the opposite. High estrogen can increase a woman's risk for stones. And it often is used as a medication to counter hyperplasia in the uterine cells. So as women are getting closer and closer to uterine cancer, the cell development, progesterone is what you give to counter it. Why does it decrease? Well, it's really similar to estrogen, so I'm not going to go through it. It's basically the same 17 things. Will also lower progesterone. One of the things, though, on number 15, so NSAIDs, the nonsteroidal anti-inflammatories, diclofenac, naproxen, after about 10 days of use, and I've seen it too with ibuprofen, after 10 days of use, it will suppress ovulation. So if you have somebody who's doing over-the-counter pain medications on the regular for something else, they have headaches, they have arthritis, they have other issues that they're taking these, and now they're hormonally crazy, It could absolutely be that their NSAID is causing it. So that you look into that. Ask them about that. Ask them how often they take over-the-counter pain medications. All right, why does it increase? Well, it could be natural. Some women just make lots of progesterone, which is super awesome. It can be because of natural support you're doing. As the example, if you give them chaste tree berry, which is also known as Vitex, I've definitely seen that herb whip women's ovaries into shape, and they make loads of progesterone. Pregnenolone, if for those of you who can get it or use it or buy it other places, it does not raise progesterone itself in circulation. It does raise progesterone metabolites and works from the brain down because it crosses the blood-brain barrier. And then obviously if you have somebody on progesterone or you've prescribed progesterone or they came into your office having been prescribed progesterone. All right, symptoms, they're real similar to estrogen, so as you all know them, we're not going to go in. So when you're testing somebody, you want to know these things. Why is my patient having these symptoms, right? Why is number one? Why do you have these and what rabbit hole do I need to go down to help treat you? What are my patient's hormone levels and how is my patient processing their hormones? So maybe it's not a production issue, it's a process issue. This is really critical to know. So let's touch on the Dutch test so we're all on the same page. All right. How many of you have done a Dutch test on yourself? How many of you know what the Dutch test is, first of all? How many of you are brand new to the Dutch test? Okay, this is the Dutch test. Dutch is an acronym. We do not test for Dutch heritage. It is an acronym. It stands for Dried Urine Test for Comprehensive Hormones. So basically what we do is we look at all your typical hormones you might get out of serum or saliva. And because it's urine, we can give you the metabolites, which is how does your body process them. So it's the best of both worlds. All your typical hormones plus how you process them in one test. The way it's collected is you urinate on little pieces of filter paper throughout the day. So instead of spitting in a tube or getting your blood drawn, you just have this little piece of filter paper that you will urinate on first thing in the morning, different paper 2 hours later, different paper around dinner, and a different paper around bed. You let them dry for 24 hours, mail them back to Regenerus, they mail them to us. Super easy. So if you have a patient that's scared of blood draws, you yourself don't like to get your blood drawn, spitting in a tube is hard. There are some conditions like Sicca and Sjogren's where they just can't produce enough saliva, and that's a really hard test for them. Most everybody has peed on something, and so it's a pretty straightforward test. Now, it looks kind of overwhelming when you look at it. You look at it and you think, what in the heck? You just start at the top, follow the black arrows down, and it goes just like a steroid pathway that many of you probably have right in front of you or can get on the break outside. The top is cholesterol. I've accidentally cut it off, but the top is cholesterol. Like I said, it's the backbone to all hormones. Then it divides on the steroid pathway. It goes to progesterone on the left, DHEA on the right. If you follow DHEA, DHEA can turn into testosterone. That turns into estrogen, which goes through the liver through phase 1 and phase 2 detox. It's the exact way it can happen in your body. That's why we do it like this. On the left side of the page, we have your progesterone, all your progesterone dials, so your alpha and your beta. You can look for your alpha person who's maybe having anxiety or not sleeping. And we also tell you the direction that your testosterone and DHEA are going. What do I mean by that? All right. I'm going to cover some stuff up. So, upper left corner, progesterone dials. You read it like a gas gauge. The two little stars are your upper and lower range. The little purple box that you see, it says menopausal range is the purple rectangular box. We give you all the ranges on all women. Men are a little different. We give you more age range specific. So, and yes, men make progesterone, and yes, we give progesterone on the male test. So with progesterone, or with the menopause, the reason we give all your ranges is because we don't know where you as a practitioner want your woman to be. Do you want her in a cycling range? Do you want her in the menopausal range? Do you want her at the high end of the menopausal range? So we give you everything. So progesterone's in the upper left corner. Diagonal to that are your estrogens, that you get dials for your E1, your E2, and your E3. So estrone, your estradiol, and your estriol. And then under that it says, it's a little bit covered up by the Regenerus logo, but it says phase 1 estrogen detoxification. So estrone and estradiol, once your body's done with them, puts them in the liver, and they get converted into either 2, 4, or 16 hydroxy, or OH. OH is the abbreviation for hydroxy. Those are your phase 1 metabolites. Now remember, your 4-hydroxy is your bad one. That's your naughty one. If you have way too much 4, you can potentially keep going down what's called the quinone pathway with a Q, and that's what can increase the risk for cancer, estrogen-related cancers. The 16, we used to always talk about the 2:16 ratio. Turns out 16 is not so cancerous as it is estrogen proliferative. So if you have a woman with high 16, she may have a lot of really heavy estrogen dominant symptoms. Heavy periods, tender breasts, moody, PMS, things like that, weight gain. And then the 2OH is where you want to go. That's the happy way. That's the healthy way. In the lower left-hand corner, you'll see part of phase 2 estrogen detox that says 2-methoxy with an M, methoxy. And there's a little gauge there. It says methylation activity. This is the active methylation using the gene COMT or COMT. This is not MTHFR. This is the active methylation. So right, when we look at phase 2, we're looking at sulfation, glucuronidation, methylation. This is methylation. This is just part of phase 2. So this is what we look at when you're looking at the Dutch test, big picture. Don't worry, we're going to break this down even more. Then we look at the androgens. Upper right-hand corner, we do look at DHEA-S. Why do we look at the S and not DHEA? Well, DHEA, no S, is very flighty, and it often is shunted into DHEA-S first, and DHEA-S doesn't have a circadian rhythm. DHEA does. So it can be really tricky to catch an accurate picture of DHEA. So pretty much all labs recognize this, and all labs give DHEA-S. But you'll see on the black arrow, there's nothing else that DHEA-S goes to. If it wants to go down to testosterone, it has to un-S and become just DHEA. Then there's testosterone, and on the left-hand side, you'll see 2 really big words. One's with an E, it's called etiocalanilone. You totally don't have to know how to pronounce that. And the other one is androsterone or androsterone, depending. That's your alpha and your beta pathway. And what I mean by that is written right in the red box. If they have high 5-alpha, they're more prone to all the PCOS symptoms. They have the acne, the facial hair, the hair loss on their head, greasy skin, greasy hair. They're the man who's getting male pattern baldness or enlarged prostate issues. And thankfully, there's a lot of natural stuff we can do to combat this besides just medication, or they have to deal with it. Now, if their 5-alpha is high, it doesn't mean they have PCOS or PCOS, but they can just have similar symptoms, and you can help address that. So like I said earlier, we just follow it like a steroid pathway. You just follow the black arrows to see what's above, and can it get below? And if it can't, now you know where the problem is, and you can work accordingly. So this is the adrenal page. We start at the top with melatonin. We do test melatonin in a urine test. We test it off the waking sample, not the nighttime sample, which people are like, well, that's crazy. Melatonin comes out at night. But remember, urine through the night goes through the kidney and then holds in the bladder. So when you wake up first thing in the morning and do that very first urine test, we're catching all the melatonin that you made at night on the piece of filter paper. So that's why it's on the waking sample. Your melatonin is just starting to rise before you go to bed, and it's not a very accurate picture of your ability to produce it through the night. So we do look at melatonin. We look at the total DHEA. So total DHEA is essentially these things added together, just because it's the adrenal page. We look at metabolized cortisol, which is basically answers the question, how much cortisol do I make in the first place, which we're going to talk about. Your free cortisol, which tells you how much is free and available. Your free cortisone, which tells you how much is inactive. Now, the body makes cortisol first, and then it has the option to convert it into cortisone. It's kind of similar to reverse T3. It's a protective mechanism, but unlike reverse T3, you can turn it back into cortisol if you need to. It's a back and forth shuttle by this fancy little enzyme called 11-beta-HSD. So we tell you both, because if you have really low free cortisol, maybe it's not an adrenal problem, it's a conversion problem to cortisone, and you have to address that. not the actual HPA excess. And at the very bottom, we tell you systemically, is your body a cortisol dominant person or a cortisone dominant person? Are you trying to fight infection and deal with stuff and be stressed out? Or is your body over it and wants you to be deactivated? Now, in a deactivated person, we never listen, right? If the body's trying to slow you down, it means you've been pushing it too much. You've been burning the candle at both ends, and it's time to rest. We never do, but the body's trying to tell you that. So we give you this huge big picture, so you get a real macroscopic view of the adrenals. On the Dutch test, we also give you this new marker that just came out. It's called 8-hydroxy-2-deoxyguanosine. Some other companies run it. How many of you are familiar with this marker? How many of you have seen it before? Laura, you don't count. But you count. One person. Okay, this is a really neat marker. What is it? It's a marker for estimating DNA damage due to oxidative stress. Now, it can be DNA damage from cancer, but DNA damage can happen from a lot of stuff. So it's really important to know, especially when you're looking at cancer risk and inflammatory people, what is going on at the DNA level. It is considered pro-mutagenic, like I said, but it doesn't necessarily mean every time they have cancer. And it can be used after exposure. So if you have somebody in a field where maybe they're getting a lot of fume exposure or paint exposure or metals exposure, or their hobbies are involved those things, you can see if they're actually absorbing and having problems with DNA damage. It's a very cool marker. It's extremely sensitive in both adults and children. So if you have, if your kids, potentially you're worried about toxin exposure or some of this inflammatory stuff. What increases it? Lots of things, unfortunately. It's a very general marker. It's not specific, but it does open your eyes to go, oh my gosh, your DNA is not happy right now, and we need to do something about this. So chronic inflammation, of course, high stress and high cortisol. It goes to show high stress and high cortisol can damage your DNA. Dang it. Increased cell turnover in cancer, obviously that's a big one. Hypertension, why? It's damaging the insides of your arteries. Blood sugar, diabetes stuff, absolutely damaging. IBD stands for irritable bowel disease. That's your ulcerative colitis and Crohn's. Chronic skin conditions, why? You're getting this chronic skin turnover, chronic damage to the skin, high inflammation. Depression, who knew? I actually saw a case come through the lab. Depression was their main complaint, severe depression. Their 8-OHDG was really high. It's really crazy how mental, emotional conditions absolutely affected the DNA level. Keep going down to the very last thing, insomnia. Anybody have any guesses as to why insomnia, chronic insomnia especially, can cause oxidative stress and DNA damage? Melatonin. Melatonin is a huge antioxidant in your system, huge. And if you're not sleeping, you're not making melatonin, and melatonin therefore can't be an antioxidant to things like this. And you don't make growth hormone. You don't make growth hormone. I liken growth hormone to like scrubbing bubbles. When your growth hormone comes out, it goes through and scrubs every single little cell in your body, nice and clean, so you wake up restored and refreshed. It's why when you're sick or healing, everyone says, go to sleep. Lay down and rest. It's growth hormone that does that reparative work. If you miss out, then you're going to have damaged DNA. So what do you do about it? Well, obviously address the cause. If they're in a field or an industry or a hobby that's chronically exposing them to things, you have to work with them on that. Increasing fruits and vegetables from lots of different colors. We say all the time, eat the rainbow. Eat the rainbow. I'm not kidding. Those antioxidants in the skin of those fruits and vegetables are really, really important. You can also just increase antioxidant intake. So there's a lot of them out there to choose from. We have a whole list. Do please be careful for those patients who are having an active cancer process. I'm not an oncologist. Cancer is not my thing at all, but several of my colleagues and friends have gone on to do extra training in oncology. They're very wary with antioxidants and an active cancer process. So just be careful. Other than high-dose vitamin C, not a lot of my friends will use like low doses of selenium or low doses of vitamin E. But if it's not cancer, absolutely use it. If it's an insomnia issue, if it's An irritable bowel disease issue, if it's more depression, like for sure, use antioxidants. Increasing their B vitamins or foods high in B vitamins, foods high in zinc or giving zinc. Those are coenzymes, just so many pathways in our body that can be quite helpful. And then, of course, looking at other big antioxidants in the system like glutathione and NAC. Specifically related, if you do genetics, look at their GST gene, the glutathione sulfur transferase gene, and see if they may have a problem, and then you do have to supplement. Because if they're missing out on their own internal antioxidant system, that's when the process breaks down. All right, why is estrogen metabolism important? Now, this section applies to males and females. Why in urine testing do we do this? Why can you not do this in serum and saliva? So, if you have a patient, male or female, who's estrogen dominant, you want to know why. And you don't just automatically put them on supplements like DIM or indole-3 carbinol without knowing the full big picture. So this is an example of a person who has, in the red, their estrone and their estradiol's quite elevated. Clearly estrogen dominant. Lots of estrogen floating around. If you follow the arrows down, you'll see a green, a red, and a blue arrow. The red arrow is high in the red, and I made it easy for you. I wrote whoa next to it. And the blue arrow, or the green arrow, which is your 2-hydroxy, I wrote sluggish clearance. You want to go down the 2. You don't want to go down the 4. So in this example, this is a phase 1 issue. They're making way too much 4. So not only the estrogen dominant, their cancer risk is high, male or female. This is a real life case. We gave this person DIM, and 2 weeks later we repeated their lab test, and you can see that their 4 is now, everything's improved. Everything has gone into the green, the 2 has gone up, and this is what you like to see. Now this is off of supplementation, but absolutely encourage your brassica family, your broccoli, your kale, your cauliflower, Brussels sprouts. Keep in mind though, I'm not talking like add an extra serving. You need to get high amounts. It's a lot that they have to eat, but at least when they're making conscious decisions in the grocery store, they can choose, okay, my practitioner told me I need to eat more of these foods, so instead of doing these vegetables over here, I'm going to focus on broccoli, kale, cauliflower, what have you, at lunch and dinner to help augment the process. And then, of course, if you want to, you can supplement. Now, in this example, we use DIM. I prefer to use DIM. It's just my soapbox. How many of you use, DIM is diindole methane. How many of you use DIM or indole-3 carbinol or have used it? Okay, so indole-3 carbinol and diindole methane are the active ingredients in those vegetables. So in the broccoli, the kale, the cauliflower, what makes them so special is that they contain this stuff just at low levels. And so that's why it's so helpful. Now, indole-3 carbinol as a supplement, if you have healthy stomach acid, it explodes into a number of different constituents, one of which is DIM. DIM is ultimately what you're going for. So my soapbox is spend the extra money and just do DIM if you're going to supplement, because most people don't have healthy stomach acid. DIM doesn't need healthy stomach acid. But a lot of companies combine them together. You can often find the DIM and the I3C mixed together, and of course, dietary recommendations. Now, what about phase 2? Well, phase 2 is the active methylation. So this is another example. This is another case where we did their genetics, and you can see that the COMT genes at the top part and the MTHFR in the bottom part of this little graph. Now, MTHFR is all in the green. They don't have an MTHFR problem. They have no issue with folate. Not a problem. No big deal. COMT, big deal. They have a problem. So you're going to treat this differently. We treat COMT and MTHFR, obviously, with some different stuff. In this case, you'll see the 2OH is at 3.4. The 2OH dial on the far right is at 3.4, whereas the 2-methoxy is at 1.5. What this means is this person is having a sluggish time getting from phase 1 to phase 2. It's like a bathtub that's filling with water and it can't drain. You need to pull the plug, drain the bathtub, and get the estrogen out of the house, for lack of a better analogy. when you're looking at estrogens on the chart that you guys have, this dairy pathway, what's missing is the right half of this super simplified stick figure graph that I'm really proud of myself for making. So basically the left-hand side is what you have on this dairy pathway. The right-hand side is if you keep going down the quinone pathway. So you will see at the 4OH box, this is the bad box, the naughty box, as it keeps going to the right on the red arrow, what's called a quinone forms. And quinones are not good because they affect what's called a depurinating adduct. So adducts are on DNA. And if the quinone binds to an adduct, it can break off. And now you have broken sections in your DNA. And the body goes, oh crap, we have holes. And it goes in to fix the hole, and mutations can occur. So the depurinating the adducts you don't want. And that's what causes cancer risk. Now you kind of have a two-stop yet measure to protect yourself. One is quinone reductase, and the other one is the GST gene, which is glutathione. Quinone reductase reacts the best to broccoli sprouts. These are people, and let's see, broccoli sprouts, there's some other sprouts, but broccoli sprouts are the most researched, and now it's escaping me. The active ingredient, though, is called sulforaphane and glucoraphanin, which I have later on just a couple of slides. Whereas GST is glutathione-based, so that's when you would do things to help support N-acetylcysteine, or NAC, or other places can actually just give glutathione. And basically what you're doing is you're trying to get the body to revert back to where you can get on a healthy pathway and avoid cancer in males and females, or get excreted properly. That's what you're going for. So now we talk about, everyone always says, what about the estrogen and progesterone ratio? I'm wondering about this ratio. On our test, it's difficult because there's so many layers. So superficially, this is what I tell people, and it's not scientific in least, I will admit right up front, you just look at the arrows. So when you're looking at the progesterone, you can see the progesterone on the left. The actual progesterone on the dial, the arrow is lower than the E1, the E2, and the E3 arrows on the right. Clearly, this person is estrogen dominant. Their estrogens basically are in the red. Their progesterone's not in the red. This is an estrogen dominant person. I don't need a ratio to tell me that. Then, what did I do? Wait for it. There we go. Then we go the next level down. What does their phase 1 look like compared to their progesterone? So same person, same progesterone, but you can see their 4OH is way in the red. Still estrogen dominant. So now they're estrogen dominant superficially, and they're estrogen dominant at phase 1 detox. And remember, phase 1 metabolites just get recirculated. They go back out and cause all sorts of problems. So you can be double estrogen dominant like this person. And let me tell you, for men and women, that sucks to be double estrogen dominant. And then lastly, you can be triple estrogen dominant because you can't get out. So if you have way too much water in the bathtub and you've got to pull the plug, it's just backing up, they're very estrogen dominant. This is a worst case scenario. This is when you have high estrone and estradiol, high naughty phase 1 metabolites, and it can't get out. This is your worst case risk for cancer, no matter what their progesterone is. But in this case, they're triple estrogen dominant is what I call it. This person is probably hurting a lot. They have a lot of symptoms. So what do you do about it? Here's what you do about it. So if you're doing supplements for phase 1, you're looking at diindolylmethane or indole-3 carbinol, and you're adding in the brassica family to their diet. Broccoli, kale, cauliflower, what have you. If it's a phase 2 issue, you're trying to pull the plug on the bathtub to drain things out, these are different things. These are things that support methylation, the active methylation. Ergo, you might need methyl donors, things like SAMe. You might need the coenzymes like P5P, that's the active ingredient in B6. Magnesium, super important for the COMT gene. Well, everything, right? Like magnesium runs the body with zinc. Choline, super important. Methionine, methylated B vitamins, and then TMG, which is trimethylglycine, or betaine. Some people call it betaine. General liver support, if you're just trying to help your poor little liver out, you're looking at things like burdock, you're looking at turmeric, you're looking at curcumin, you're looking at onions and garlic, you're looking at artichoke, any of those liver supportive herbs, foods, supplements. Sulforaphane and glucoraphanin, again, that's what supports quinone reductase. Have them to eat broccoli sprouts, put it in their smoothie, put it on their salads. I don't care, just get it in. Looking at glutathione and NAC or NAC, absolutely. Quercetin and resveratrol can be quite helpful, but they don't absorb in the body very well. So while quercetin is great for things like allergies, and resveratrol is great for things like, they say, anti-aging, they just don't absorb very well. And so you can give them, but I find that the other stuff is much more potent. And then I have the list of foods that are really quite good for the liver. So knowing estrogen metabolism, knowing their phase 1 and phase 2 breakdown, helps you direct diet and treatment. You don't give DIM to a phase 2 person. They don't need it. Just like you don't necessarily give methionine to a phase 1 person. All right, what else do estrogen and progesterone affect? Well, how does estrogen affect central serotonin? Turns out, positively. We need estrogen in the brain. Super important. 5-HT is a fancy abbreviation for serotonin, if you didn't know. So low 5-HT, obviously we know mood disorders, inability to handle stress, think depression, things like that. The dorsal raphe nucleus in the brainstem is the largest serotonergic nucleus, and it has a huge portion of serotonin innervation to the forebrain. If you forgot, I have it there. The forebrain is basically the big part. It's the cerebrum, the thalamus, the hypothalamus, the pituitary, and the limbic system. And for our purposes, we're really talking about the hypothalamus and pituitary because that's what it comes to with hormones. 40% of serotonin neurons have estrogen receptor and alpha and estrogen receptor beta receptors on them. 40%, which means estrogen and serotonin in your brain are really, really connected and rely upon each other. So as an example, estrogen receptor beta upregulates the mitochondrial RNA of tryptophan hydroxylase. This is the rate-limiting step to get from tryptophan to 5-HTP. What does this mean for you guys in practice? This means if you have a person who has low estrogen, then they're not going to get serotonin support, and they're probably at more risk for depression and the inability to handle stress. This is the woman who had really high, healthy levels of estrogen when she's pregnant, and then she delivers, and her estrogen crashes down, and now she has postpartum depression. She needs that estrogen to get that 5-HTP to make serotonin. That's basically what it means for you guys in practice. Animal studies show that estrogen, especially estradiol, increases 5-HT transporter, so transportation of serotonin, and serotonin reuptake transporter, so pulling it back in. So if you don't have estrogen, then you miss out on all these key factors for supporting your serotonin. And we absolutely hear this all the time. We hear of women at any age with low estrogen report low mood, worse anxiety. We hear of postpartum depression all the time, and this is often a big reason why. And sometimes, not always, sometimes I can tell what women are going to get postpartum depression if I've seen them before they got pregnant and I know what their estrogen situation is, or I know what their serotonin situation is. Because if they have healthy levels of serotonin and estrogen going into pregnancy, and they get pregnant and their estrogen goes up, and they have the baby and their estrogen goes down, but their serotonin's still healthy, their serotonin will pull the weight and carry them through until their estrogen comes back up again. But if they start out preconception not that strong in estrogen or progesterone, both of them are on the low end, or one of them's on the low end, and now they get pregnant and then they deliver, it's not like it got better. It's not like serotonin, healed itself. And it's not like having a newborn baby is going to make the serotonin go up. It's a little bit stressful to have one. So I can almost predict who's going to get postpartum. Not always, but often if I've seen them ahead of time and I'm looking at those two factors. How does it affect dopamine? Man, we love dopamine. Dopamine is our reward center. It helps with addictions and cravings like chocolate, for me, motor control, and memory. In the periphery, it inhibits the norapi or the noradrenaline release. It increases sodium excretion, so it helps quite a bit with water retention. It modulates insulin production, and it protects the gastric mucosa. Really, really important for GI conditions. Dopamine is made in the medulla of the adrenal glands, just FYI, and it cannot cross the blood-brain barrier. Therefore, it has to be made in the CNS, with the basal ganglia and the substantia nigra, and the ventral tegmental areas, primarily, if you nerd out and want to know that stuff, to exert an effect there. So dopamine is made in the adrenals, and dopamine is made in the brain. And they can't go across and help each other out. So normal estradiol levels helps dopamine levels in the prefrontal cortex for working memory. How does this translate to your practice? You have a woman entering into menopause coming to you and go, I can't remember anything anymore. I don't know what's wrong with me. Her estrogen levels are going down, and therefore she's lost that working memory. You tell her something and she's like, yeah, all right, right. What? She has to write everything down. The women who come in and go, I have to make lists now. Or they were always a list person and now they're a mega list person. They have lists for their lists. These are these people. They've lost estrogen, so they lose their working memory. This is a study, complete loss of estrogen. So in this study, with a full hysterectomy, ovaries removed, can result in loss of dopaminergic cells in the substantia nigra. And women who've had a full hysterectomy, losing their memory is a big complaint of theirs. Weight gain is another big one, but memory loss, like almost overnight. They're like, oh my gosh, it must be Alzheimer's. It must be dementia. I'm like, no, it's loss of estrogen. You're missing out on that dopamine. It does also modulate mesolimbic dopamine system, and female rats are more motivated. When women lose estrogen, they often say like, I don't really feel like doing stuff like I used to. I don't really get as much joy as I used to. Or they finally crave more to try to stimulate that reward system that's in the brain. And it can be neuroprotective. Estrogen can be neuroprotective to the dopamine system in the central nervous system. So again, too much estrogen, bad. We just talked about it several slides ago. If they go down the quinone pathway, it increases cancer risk. But not enough estrogen, it makes her not remember stuff, and she's not motivated, and now she has cravings issues, and she's not fun to be around. So estrogen binding globulins. We talked about cortisol binding globulin, but there are other ones, sex hormone and thyroid binding. Turns out estrogen raises all of them, all the binding globulins, which means you have less free hormone available to you. If you have too much sex hormone binding globulin, her testosterone and her estrogen go down. What's the number one cause of this? The birth control pill. And the longer she's on the birth control pill, the more permanent her rise in sex hormone binding globulin is, which means the more permanent she will have less testosterone and less estrogen. Again, when I rule part of the universe, I will change this because it's not fair. I mean, the pill is just wrong in a lot of ways. But when they go on the pill, and they've been on it forever. In fact, I got an email today. A woman had been on the pill from 16 years old to 40 years old and was now off the pill, and all of her hormones are in the tank. And I was like, I know. Because you've been on this suppressive pill for most of your adult life heading into menopause, and of course you don't have any testosterone. You have raised all the binding globulins that has eaten up all your testosterone. It's no wonder you have no sex drive. And it's super difficult to get back because I'm fighting against years of synthetic hormones that has made a deep imprint in the body. It's terrible. Thyroid. We see this with thyroid. If they have too much estrogen, estrogen-dominant women, the birth control pill, menopausal women who are on estrogen replacement, their thyroid gets crazy. It's because thyroid binding globulin eats up the free thyroid that's supposed to be circulating and helping. And the same goes for cortisol. So genetics. Well, what does estrogen do? It can lower the COMT gene. It's supposed to be a checks and balances. Sometimes the COMT gene is not doing what it's supposed to do, so estrogen helps to diminish it. But if you get too much suppression of it, then you get anxiety, insomnia, worry, pain, stress, paranoia feeling, stressed out, wired, and OCD. Why? Because dopamine, noradrenaline, adrenaline can't break down. So it's a balance. A little bit of estrogen that's trying to get these things slowed down to give you some energy. You need just a little adrenaline to get through your day. Estrogen goes, cool. I will help slow the COMT gene, give you a little adrenaline. Too much, and now you're a wired, anxious OCD mess. It's a balance. Same goes for the MAOA gene. That's your serotonin, your melatonin. Again, adrenaline, noradrenaline, dopamine, phenylethylamine. They can't break down, and the symptoms are really super similar. A little bit of estrogen. Again, it's to help you with the melatonin, sleep. It's to help you with energy. It's to help you with depression, fight depression. Too much, and we crash. We get all these awful symptoms. What about progesterone? This one we've already talked about. This is where I explain this a little more deeply, how progesterone helps with GABA in the brain. Again, it's those alpha metabolites. If you can support progesterone to get her alpha metabolites up, it helps her sleep and it helps her anxiety, which I go way more into on this slide. We've already talked about it. Okay. So the next part of the slides are all treatment stuff. It's a little bit early, but I think we should take a break. Let's take a break because we've blown through. Okay, how do you address your patients? How many times you've had a patient and this is what you've had to say to them? I can fix you, but you are a disaster. You are a train wreck, and I need to change everything about you. It doesn't usually go over well with patients when you tell them that right off the bat. Baby steps is usually the best thing, but we get these patients all the time. This is what I do. This is just my soapbox. This is how I think. This is mine. I created this. But it's nothing special. You see it all over. So basically what I do is I address the blood sugar and insulin, and I address the gut health. By gut health, I mean everything from what they put in said mouth and what comes out the other end. Can they absorb? Do they have SIBO? Do they have gut infections, candida, anything? Diseases? Do they have ulcerative colitis? Irritable bowel disease, any of that. And then I work to eliminate that first. The reason I do that, and I was just talking to somebody, but now I can't remember who I was talking to. If you have a lot of gut infections, or even a gut infection, and then you go, let's pretend, the example was I'm low in iron, but I have a candida infection in my gut, or SIBO. Well, if you put them on iron, they're not going to absorb very much of it at all, because there's so much inflammation happening down there. Then that's why they're probably not high in iron when you do a blood test on them. So you treat the gut first and then add in the extra supplements later. Now you can consider using the dissolvable kind, like sublingual. You can do oral, you can, not oral, liquid supplements. You can consider the creams, the transdermal, like the magnesium cream that I said that I use, to bypass the gut. But if that's not an option for you, no problem. Address the gut, fix their diet, and then go forward so they can absorb what you're about to give them. After that, work on the thyroid and the adrenal. And the thyroid and the adrenal are very best friends. They communicate all day long via text, super fast text, and they tell each other what's up. And then if one starts to fail, the other one starts to fail, and vice versa. And so that's the next level. And then after that, I look at the sex hormones. Because how many times have you been working with your patients and you find by fixing their diet and addressing their blood sugar, their sex hormone problems get better, or their adrenal problems get better all the time. But sometimes you have to go all the way to the top of the pyramid. That's totally cool. So these are my treatment basics that I like to do, and you hear these all the time. Get their blood sugar under control. If you have somebody with an HPA axis issue, and the HPA axis main job is to address blood sugar and insulin, then go there first. Make sure they're eating appropriately. Make sure that they're not insulin resistant. Make sure they're not putting crap in their mouth. Nobody judged the fact that I just ate those corn crisps with chocolate on the top of them. They were amazing, but I'm sure they did terrible things to my blood sugar. but I will be getting more on my way out of here. Eat healthy. I just said, right? You are what you eat. You are what you absorb. You should probably avoid your food allergies or your food intolerances. You should probably just blanketly avoid gluten, period. It's probably just not good for you. There's so much research about that. My brother and my sister-in-law were just at my house 2 weekends ago, and most of my friends are, we hang out with people that are like us. So most of my friends are naturopaths, and most of my friends are gluten-free and dairy-free and soy-free, and they eat organic and all this stuff. And one day my sister-in-law said, I have to go find gluten. I can't handle this anymore. I was like, oh, honey, I think you need to be on a gluten-free diet, but don't treat your family. Minimizing sugar, of course, minimizing aspartame and MSG. Remember, glutamate and MSG is very excitatory and can destroy brain neurons. Now, the counter, does anyone know the counter to glutamate? What's the great neurotransmitter that you can use, or amino acid that can help with countering glutamate. It's theanine. Are you all familiar with L-theanine? It counters glutamate. It's a great one. So if you have somebody with brain on fire, who's having a lot of anxiety, sleep issues, besides progesterone, besides cortisol, it could be glutamate related. And theanine's really safe, and it's a good one. Eliminating infections or inflammation and test for infections. I find a lot of times practitioners get really focused on cortisol, and if it's not cortisol, they can't figure it out. So for example, I'm really, really tired, and they do adrenal testing on them, and their cortisol is normal. They're like, well, your test has to be wrong. I'm like, well, cortisol is not the only thing that causes fatigue. A lot of things in the body and in the environment and what you can get exposed to and pick up on can cause fatigue. So test them for Lyme, test them for Epstein-Barr, cytomegalovirus, and other crazy viruses. Check their thyroid, look at their nutrients. And a lot of things can cause that stuff. Obviously, reduce stress, find joy, do things that make you happy, daily positive affirmations. I was on a podcast the other day, and she's like, what do you recommend for patients to do to be happy and to reduce stress? And it came to me, I was like, pet a dog. Right? Like pet a dog. I mean, unless you're not a dog person or you're allergic to him. Make sure it's a nice dog. So there's some caveats. But like when you pet a dog, instantly all your oxytocin goes up and your endorphins come out, and dogs just make you happy because they just love you blindly. And so pet a dog. Cats, not so much. I mean, some cats, but let's be honest. Not really. They're not like dogs. Use your no button. There used to be this ad on TV, and it was called the easy button, and it was for ordering office supplies, and they would press the easy button, and automatically office supplies would come on, show up at the office. And I was like, I need a no button. I want to press a no button, and the person just goes away, or the thing just goes away. And just remember, it's okay to say no. Say yes to the stuff that fulfills you, not the stuff that's going to stress you out and drag you down. Because as you get older, your trampoline gets thinner and your HPA access can't deal with it as well. Practitioner, heal thyself, right? We are the most giving of all the practitioners as functional medicine practitioners, and yet usually our health is terrible. Get enough water daily. Minimize alcohol. It is a general hypothalamic depressant, and as we know, it can increase estrogen in men and women. Try to eliminate environmental toxicants. Exercise most days of the week. Be real particular on your exercise, though. This was brought up at last night's lecture, and I forgot to address it within the lecture. But if you have somebody that's really high cortisol, or borderline high cortisol, and they do cardio, think about that. They have high cortisol, so the body goes, we are running from the tiger all the time. And then they go run on the treadmill, or run outside, or get on the elliptical machine. They're just going to push their cortisol higher. So be real careful with the type of exercise you're recommending to patients. And sometimes you have to tell your patients, hey, I know you like to exercise, but you have to slow it down. I need you to do nourishing things like yoga or stretching, or go for a stroll. Now, if you tell some type A patients, I want you to walk, like just go for a walk, and I learned this the hard way early in practice, they become like the next power walkers of America. I mean, or wherever. Like they just take it to a new extreme and they become very, very serious. I'm like, no, No, just go for a walk. Just nourish yourself. You don't have to make it to a competitive sport every single time. On the flip side, though, if you're trying to build up androgens, if you're trying to get their testosterone higher, then you need to do anabolic work. That's your heavy weightlifting. Those are your HIIT exercises, your high intensity training. So it what the person looks like depends on what you recommend. And I'm not saying no cardio. I'm not opposed to cardio at all. Cardio is where I think when I do cardio. But I'm also really careful if I'm really having a stressful day, or I know I can tell my cortisol is higher. I don't do as much cardio, or I just go for a walk, because I don't want to push it higher and make my body think I'm running for more tigers. Sleep at least 7 hours. We talked about this. You want to hit all your REM cycles. You want to increase your growth hormone. And of course, you want to increase your melatonin. For the love of God, get off your phones and your tablets and your computers. I am 100% guilty of this. My husband is military. He has zero medical background, but he listens to everything I say when it comes to medicine. So when I'm on my phone in bed, he's like, "You're killing your melatonin." Like, don't listen to me. So now I have those ever so sexy, orange blue blocking glasses, so I can still stay on my phone before bed, which is so bad, but it's a step in the right direction. I'll get there. Get a massage, see an acupuncturist, see a therapist, do what it takes, have your patients do what it takes, to really get back in touch with themselves and say no and heal and nourish. So what are adaptogens? What can you recommend when it comes to actual things you can take besides lifestyle changes, dietary changes, and other things to help nourish the being? So what is an adaptogen? Well, according to David Winston, who's an herbalist that I really, really like, they work through the HPA and the sympathoregulatory system and help reduce cortisol-induced mitochondrial dysfunction. My favorite definition, however, is Wikipedia's. Wikipedia is amazing. Adaptogens or adaptogenic substances, compounds, herbs, or practices refers to the pharmacological concept whereby administration results in stabilization of physiological processes and promotion of homeostasis. For example, decreased cellular sensitivity to stress. That's our ultimate goal, right? We want stabilization of homeostasis. That's what we want our little adaptogen to do when we take it. The thing, though, is adaptogens work on all levels of the body. So what I will hear is, I took adaptogens and I felt better, so I knew I had adrenal fatigue. That test on Facebook that I took was right. And I'm like, okay, really? This is what I say all the time. That's like me saying, when I put on yoga pants, I always do yoga. Yeah, no. Yoga pants are great for everything. They're like the adaptogen of clothing for women. So be aware adaptogens affect the immune system, the central nervous system, the cardiovascular system, the digestive system, and the HPA system. We primarily focus on the HPA, but it does everything. That's why they're called an adaptogen. Here are the commonly accepted ones. There's a little bit debate in the world of herbs, which is a true adaptogen and which is not. So these are generally okay. Ashwagandha, everyone, of course, Panax quinquefolium, Asian ginseng, cordyceps. Cordyceps is a really great one when you're trying to improve communication between the hypothalamus and the pituitary. So when you're trying to use brain stuff, brain support, adding cordyceps. Maca will do it too. Eleutherococcus and, of course, rhodiola. The same herbalist, I did not know this, and some of you who are herbalists may disagree, but David Winston says that rhodiola can be really drying. So if you have a patient who has wet hot flashes, fantastic. If you have somebody that's already has dry eyes, dry mouth, vaginal dryness, rhodiola in like a high dose for long periods may not be the best for her. So the example that I give is I was sitting, and this is where I learned about this. I was sitting in David's lecture with my very best friend who the backstory is she said, "Oh my gosh, I have the driest eyes. I'm constantly using eye drops. I don't understand." She doesn't wear contacts or glasses. And she's like, I don't know why my eyes are so dry lately. So we're sitting in the lecture and David says, rhodiola is very dry. And if you take rhodiola, blah, 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 dry eyes, dry mouth, vaginal dryness. And she looked at me and she goes, "I have been taking 1,000 milligrams of rhodiola for the last 4 months." And I was like, "Stop the rhodiola!" don't do it. So she stopped the rhodiola, and it did help. It didn't cure everything, but it did make an impact on her. So my N of 1 was my best friend, and it turned out it was true. Probably adaptogens, but mixed reviews, because I think they're a little more potent in affecting hormone levels. Maca is a great example. A lot of people will give maca with low cortisol, but also low testosterone and low estrogen. And it can be helpful for those depleted women where you can't use hormones. Maca is a good option. And again, maca helps the brain, hypothalamus to pituitary communication. Codenopsis. Shishandra, I really like for the angry liver chi stagnation woman. She's the angry PMS person. She's the menopausal woman who is suddenly now mad. Shishandra can be really helpful for that. Astragalus are for those who get sick all the time. They have a really weak immune system. So it's kind of, again, a lot of these herbs are 2 for 1. Raponticum, I haven't found as much success with Raponticum, but I know a lot of supplement companies have jumped on that bandwagon and market it quite heavily. Reishi, we will learn later, reishi is really great for helping the people who have too much testosterone and DHEA causing acne and facial hair, male pattern baldness, what have you. It's called a 5-alpha blocker, but we will talk, don't worry, I have a whole slide on it. But again, it's a 2 for 1. We pronounce it gynostemma, which is for blood sugar also, and then shilajit, which I really like, the Himalayan tar. I find that can be really quite helpful. Basic nutrients. So from a vitamin and mineral point of view, remember the adrenal glands require for life vitamin C and pantothenic acid, vitamin B5. Humans are one of the few mammals that cannot make their own vitamin C. Again, such a design flaw. So many other mammals, like, this is terrible. On Wikipedia, I learned that when mountain goats get stressed out, their vitamin C levels go up like 6,000%. Why does the mountain goat get that and we don't? Like, what stresses out a mountain goat? I mean, seriously, compared to our life. So, what'd you say?
A puma.
Yeah, well, yeah, okay. So they have real animals chasing them, but still. I wish humans can make their own vitamin C. So I will have patients say to me, of course, everyone knows the side effects of too much vitamin C is you get loose bowel movements. And so I have patients say, gosh, normally when I take 1,000 milligrams of vitamin C, I have loose stools. But yet lately I've been taking 5,000 without issue. Like, I think your adrenal glands need your vitamin C. Your demand is a lot higher. It's okay. Same for vitamin B5. I use higher doses. I'll use 500 milligrams of B5, 1,000 milligrams of B5 in a really stressful situation when I'm trying to really help just nourish the gland itself. Zinc, much like magnesium, seems to be required for everything in the body, like every process. If it's not zinc, it's magnesium. Iron, be aware with iron when you do blood tests, check them for iron, check them for their ferritin. And again, though, if they have a lot of GI distress, fix that first. Because with iron, it's either they don't get it in, they don't absorb it, or they bleed it out. It's one of the 3 things with women. Well, men too. So if they're not eating, if they're a vegan or vegetarian who's not aware of it, of how to get iron in, like consult them on diet. But if they are eating iron-rich foods, then make sure they're absorbing. And ask her about her menstrual cycles. Does she bleed quite heavily? What does heavily mean to her? How much blood is coming out? Does she notice blood in her stool? Same for men. Do you notice blood in your stools? Do you ever have bloody stools? Because men can lose iron just like women can. Magnesium and then of course selenium can be really helpful for the HPA axis. And selenium is a fantastic antioxidant and it's fantastic for the thyroid. Really helpful for getting the T4 to T3 conversion. So if you have a conversion patient, I'll use like 200 to 600 micrograms of selenium. You can get toxicity with selenium. Don't go above 1,000 with that. And then selenium's high in Brazil nuts. Yes?
Is there a particular type of magnesium which has a good affinity for the HPA axis?
Is there a particular type of magnesium? And so with the magnesium I usually do is like citrate malate or the kind in the Epsom salt baths, which is the magnesium sulfate. There you go. Yeah. Okay, so here's some examples I want to show you with what we've been talking about and what it might look like on lab work. This is a 40-year-old female inflammation and obesity case. Her chief complaints are fatigue, weight gain in the abdomen. I keep forgetting to convert this. 40 pounds, which is a lot in the last 2 years. She's had joint pain, specifically in her knees and shoulders, and a lot of gut issues. She's having bloating and diarrhea. We did a stool test on her. Candida and blastocystis came up. She has low vitamin D, which of course is super common in Portland, because like I said, we get about 24 hours of sun and that's it. And then borderline high blood sugar. So when you look at her case, you're like, okay, she has infections in the gut. She has inflammation in her joints. She has poor vitamin D, so her immune system's probably not doing that great. And she's a borderline diabetic. Blood sugar issues, inflammation. I ran her adrenal results, and they look like this. Metabolized cortisol is extremely high, the top dial. And in the bottom dial, where it says free cortisol equals high. She's pumping out tons of cortisol. Why? She's massively inflamed. Cortisol helps balance blood sugar and deal with inflammation. It's doing its job. Now, in the short term, this is what you want. In the long term, this is not what you want. Then you get tissue damage and all the long-term effects. If you ever have a patient that you treat for high cortisol, you suppress their cortisol and they get worse, the cortisol was actually helping them, not hurting them. So just as an example, I had a rheumatoid arthritis patient, I was talking to a practitioner who had a rheumatoid arthritis patient, really high cortisol like this, suppressed her cortisol, and all her joint pain flared up. And I was like, stop. She needs the cortisol. It's actually combating the rheumatoid arthritis as best it can. And by suppressing it, you're making her worse. But now in this woman's case, really high cortisol all over the place, am I going to instantly, is my first thought going to be, I'm going to suppress your cortisol, knowing what I know on this slide? No, of course not. I'm going to address her, I'm going to do the pyramid. I'm going to address her blood sugar, change her diet, and work on the gut. That's what I'm going to do. And over time, this will naturally go down because I'm addressing the cause. You don't have to jump on the adrenal bandwagon right away, as long as you know where the cause is. Now, there are other reasons for high metabolized cortisol. Why would somebody pump out tons of cortisol? Well, long-term stress, inflammation and infection, obesity. This is terrible. So fat tissue itself has its own inflammatory cytokines, and it has this pesky little enzyme called 11-beta-HSD1 that takes cortisone, that's inactive, turns it to cortisol, that's active, and now you have cortisol amplified right in the fat tissue, and the fat tissue gets bigger. It's a horrible design flaw. I will change it when I get there. Apparently I have a long wait. So fat tissue can make cortisol. So you think it's the HPA axis, and really it's all the excess fat tissue doing it for you. Insulin dysregulation, which we've talked about, and hyperthyroid, believe it or not, will raise cortisol. Because hyperthyroid is like pressing on the gas in a car. It turns everything up, including cortisol. So what do? This is what you do. First of all, you want to find out what's hyperstimulating her HPA axis and address it. Address the cause. In that case, I would work on sugars, diet, and gut, and I would start there. That's where I would go. If they're really high all day long, definitely rule out the bad conditions like Cushing's disease. Now, Cushing's is a tumor-related disease. Tumors don't follow a circadian rhythm. So if it's a high flat line, that's probably Cushing's. If it's high, but it has a circadian rhythm, it's just high, all her points are high, probably not Cushing's, because tumors don't follow a circadian rhythm. Nutrients and brain support, like we have talked about slides back, adaptogens like we talked about slides back. How many of you are familiar with or use flower essences? Do you guys, the Bach flower remedies? So white chestnut is a really, really good one for the overactive mind. It's for people who can't turn their brain off at night to sleep, and they just run through all the nebulous stuff you should not be running through before you go to bed, even though they're so tired. The calming adrenal herbs I don't know if I talk about those. I think I might have forgotten that slide. So the calming adrenal herbs are things like holy basil, skullcap, magnolia, theanine, which I've talked about for glutamate, phosphatidylserine. Are you guys familiar with phosphatidylserine? That's a good one. And then meditation, a lot of good research on meditation to help bring cortisol down. Next case, 32-year-old female with fatigue and depression. Fatigue worsening over the last few years. She's had ongoing depression since she got into a car accident 2 years ago. What does that tell you? She probably hit her head, right? If she's having depression is a central nervous system thing. She probably hit her head, and she's having hypothalamic pituitary issues. She has a history of allergies and asthma, and as a result, she uses a steroid inhaler and steroid nasal spray as needed. This is really good to know. Steroids suppress the HPA axis. The higher the dose, the more you use it, the more suppressed you get. So we think of steroids like prednisone, like oral or injectable prednisone. You guys have prednisone? Yeah. Okay, just want to make sure. But we forget in allergy and asthma season, people will do this every day. Or people who have exercise-induced asthma, they'll use their inhaler, their Ventolin or albuterol inhaler. If they exercise most every day or 5 days a week, they're using it every day. And it will suppress their HPA axis. And, she's a Portlander, so she has low vitamin D. This is what she looks like. She's the complete opposite. Everything is very, very low, down into the yellow. Low metabolized, low free cortisol on the right. On the left-hand side, you will see it says deactivating to cortisone systemically. So not only does she not make that much, she's deactivating whatever she has. So she has like a triple whammy against her. In her case, I think it's a combination of the car accident causing brain issues, traumatic brain injury, and her allergy and asthma inhaler nasal spray situation, suppressing whatever she has left. So in her case, what I did is I don't do any brain work. Neurology is not my thing. So I actually referred her to a colleague of mine who does neurologic chiropractic work and neurofeedback, where they put the little electrodes on and watch your waves and have you do cool stuff. But I worked on the allergy and asthma stuff to try to get her off her inhaler and her nasal spray so she'd stop suppressing her HPA axis. Now people will say, I can't get off my inhaler. I can't survive allergy season without my nasal spray. What do I do? So nothing is stronger. There's no adaptogen stronger than a steroid. There just isn't. Like ashwagandha is not going to win up against prednisone or Ventolin. But I still put them on HPA axis support. I still put them on adaptogens just to try to help keep their head above water until I can get their allergy and asthma symptoms better under control and go from there. However, why would metabolized cortisol be low? Why is everything low? There's a number of reasons. Hypothyroid. When the thyroid slows down, it slows everything down. It slows down metabolism. It slows down digestion. You get constipation. It slows down hair growth. You get the hair, hair falls out. It also slows down production of cortisol. And then cortisol goes down. If you have an HPA axis miscommunication, if the hypothalamus doesn't talk to the pituitary, or the pituitary doesn't talk to the adrenals, then how are the adrenals going to know to make cortisol? They're not. They're not going to get the message. It's not going to happen. Again, we talked about steroids, opioid pain medication. This is a real big problem where I'm from. People will come out of surgery on pain medications and then they'll get addicted and they'll buy it on the street, or they'll buy it, from friends or family members who've had surgery but didn't need their pills anymore, and they'll do them every day, and it will greatly suppress their HPA axis. In fact, I was telling Laura this on the train. I had a doctor I was consulting with, and the patient's results looked like this, very, very low, very, very low. And I was running through this list with the practitioner, and I said, opioids, and he was like, no, there's no chance it's opioids. I don't give him opioids. I was like, all right, well, check in with the patient. 10 minutes later, the doctor called me back and said, hey, I ran through this list with the patient, and apparently they do recreational opioid pain medication. Like, recreational? What is recreational opioid? And I'm like, well, it's more than recreational because they look like this, which means they're probably doing it every day to get this kind of suppression. Once a week, obviously I'm I'm not encouraging opioid recreational, but like a once a week habit is probably not going to do this. But every day, absolutely. It's weird what your patients don't tell you. Gotta ask. Accutane. Do you guys know what Accutane is for acne? Do you call it Accutane or do you call it There you go. Yep, that's what it is. So I had another doctor I was consulting with who the Dutch test came back, looked very similar to this. That doctor sent it to an endocrinologist. The endocrinologist said, oh, it's pseudo-Addison's. And I was like, there's no such thing as pseudo-Addison's. What's that? So believe it or not, the endocrinologist did a bunch of work and found that Accutane can irreversibly kill off cells in the hypothalamus. What? So this person did the Dutch test, happened to be on it for her acne. She went off of it, and thankfully, after about 3 or 4 months, she rebounded. Her HPA axis started working again. But when you look in the literature, there are studies that show the hypothalamus, cells in the hypothalamus permanently die. It's terrible.
Is this what causes depression in teens?
Yes, actually, my stepson was on it 2 years ago, and he admitted to me last year that he didn't finish his whole I didn't put him on it, of course. So his mom did, and so he admitted to me last year. He's like, "Didn't you notice I was a whole different person?" He's like, "I really noticed a huge mood shift," which we did, but he was also 16. 16-year-old boys aren't always that fun. So he stopped his prescription early, and he noticed a huge difference by going off of it. And so I explained this to him and was like, well, actually, let me tell you what it might do in some people. TBI, so anything that affects traumatic brain injury, affects the brain, sports injuries, military, car accidents, slip and falls where you hit your head, any kind of traumatic event could definitely, anything that shakes up the hypothalamus and the pituitary can really result in issues. Now, usually, if that's the case, they also have low hormones. Their hypothalamic pituitary ovary or gonad system is affected as well. Anorexia. With anorexia, what happens is the liver will slow down clearance of cortisol to survive. So it'll slow down processing cortisol, free cortisol, to keep free cortisol around longer. Because you have total, and then you have free. So anorexia slows down the breakdown of total, so you have lots of free to survive. And it can last for a long time. I've definitely had patients with a history of anorexia when they were younger, a significant history, 5 or 10 years in their teens or university years, and now they're in their 40s or 50s and they still struggle because the liver has permanently downregulated these enzymes. It can be really unfortunate. And then poor liver function. If your liver's screwed up, your hormones are screwed up. That's the non-scientific terminology for that.
But it's true.
But it's true, right? Everyone gets that. Okay, what do you do? What the heck do you do? So it's very similar. You want to find the cause. If it's a lack of communication, address that. Double check if they're on steroids. Ask them. Double check if they're on opioids, even recreationally. Check that. Check if they're on any kind of acne medication. Check if their history of traumatic brain injury. Have them run through that with you. And check if it's Addison's. Addison's is the opposite of Cushing's. So it's when the actual adrenals really do give out. It's true, legit adrenal fatigue. That's Addison's. So if everything is very, very low and flatlined, you might have to work. And nothing else, they're not on any of these medications. They've never hit their head. They're not on an inhaler. Like definitely, maybe they have autoimmune adrenal. And they have a 40% more chance of autoimmune adrenal if they have Hashimoto's, celiac. Wait for it. Hold on. Dang it. Hashimoto's, celiac, and there's type 1 diabetes, and there's a fourth one. So 5 of them run together. So these 5 autoimmune, if you have one, you have a 40% chance of getting one of the other ones. So type 1 diabetes, celiac, Hashimoto's, Addison's, and I cannot remember what the 5th one is, but it'll probably come to me later. So if they have Hashimoto's, they have celiac, and they look really low and flatline, consider testing them. Double check their thyroid, of course. If they're hypothyroid, they may have really low cortisol. It's the thyroid's fault, not the adrenal's fault. And then treatment, adrenal and brain glandulars, if you do them. How many of you are familiar or use glandulars, like adrenal cortex and whatnot? Okay. You can also get hypothalamus and pituitary's glandular. Basically what they do is they take the tissue of the gland and they remove all the hormone and just leave the tissue left over. I know it sounds awful, but it is, this stuff, glandulars are awesome, man. They work really well. Not that you can get DHEA, but they come in on DHEA or somebody can prescribe DHEA for them, or if they go somewhere and they can get DHEA. You can do that. And hydrocortisone, so sometimes some practitioners will prescribe, so hydrocortisone is different than prednisone, it's different than a steroid. Hydrocortisone's real cortisol. So sometimes they'll prescribe real cortisol just to help give them some oomph, give them some extra energy to be motivated to change their diet, to be motivated to take their supplements, to be motivated to get through their day, and then wean them off of it. So I do see that. Obviously, any of the nutrients, the brain support we talked about, adaptogens, and then licorice. How many people use the herb licorice with patients for adrenals? Okay, so licorice, what licorice does is it keeps free cortisol hanging around longer. It stops the breakdown of cortisol. So if you have a really low cortisol person, licorice can be helpful. And the real licorice, not the like the real old time licorice, not the like crap licorice they have now that's full of sugar and dye and all that other stuff, but real black licorice counts. It actually has glycyrrhizin in it and can make an impact on adrenals. You do have to watch out for hypokalemia, which is a fancy word for low potassium. Licorice can deplete potassium. And you have to watch out for hypertension, high blood pressure. Licorice will raise blood pressure. But that's great if you have a patient who has low blood pressure because their HPA axis is depleted and low. Not so great if you have somebody with high blood pressure. It'll make it higher. All right. Thyroid. 55-year-old female suspects thyroid. Chief complaints, fatigue the last several years. She's gaining weight. She has all the typical thyroid stuff. Cold hands and feet, ongoing digestive issues, hair loss from the head, night sweats. Her thyroid serum levels, her blood levels, are very classic. She has elevated TSH, low free T3, positive antibodies. She has Hashimoto's. So I ran blood work at the same time I ran the Dutch test on her. And believe it or not, when you do dried urine testing, you can see a hypothyroid pattern. And I have it written out here. So the hypothyroid pattern is when the metabolized cortisol is low. So total cortisol is low, but free cortisol is high. So you get this opposite on the dials. So what will happen a lot of times is people will run our test, and I'll go, have you checked their thyroid lately? Because they have a thyroid pattern. They're like, oh no. Or, oh yeah, turns out they have a thyroid problem. In this case, when the pattern looks like this, you want to make sure you absolutely treat the thyroid in addition to the adrenals. Now, in school, a lot of times we're taught you treat the adrenals first, and then the thyroid will follow along. In this instance, when it looks like this, you have to treat the thyroid first or in conjunction with the adrenals. If you just treat the adrenals, the thyroid is not going to get better, and you have that stubborn patient who gets better for a while and then relapses or never quite gets better. Because you have to address the thyroid. The thyroid is making a bigger impact on the adrenals. It's slowing everything down. So you got to figure out what's going on with the thyroid, and then the adrenals rebound. So with hypothyroid, the most common reason metabolized cortisol is low and free cortisol is elevated. It's just a pattern that we pick up on our test. It's not absolutely diagnostic, but it can point you in the right direction. Like, I was right. It's probably her thyroid, and then you can address it. So what do? Well, check the full panel, obviously, and then if you're doing blood work, or suggesting that she see her somebody who does blood work, I really highly recommend you guys start doing reverse T3 also if you're not doing it yet. So the reason I like reverse T3 is you can do the T3 reverse T3 ratio, and that gives you some insight into something called cellular hypothyroid or peripheral hypothyroid. If you don't remember from, way back, so TSH is only an indicator of T3 in the pituitary. It doesn't tell you about T3 in your foot, in your knee, in your, thigh, in your intestines. It only tells you what T3 is doing in your pituitary. So what people are doing now is a T3 reverse T3 ratio. You can look it up online. And it gives you insight as to, are they able to get that T3 into the cells in the periphery? Because what happens is TSH can look totally normal, but they have all the classic symptoms because the T3 is not getting into the cells out in the periphery. You can also have a similar pattern with liver, with just clogged up liver. Like I said earlier, if the liver's screwed up, it screws up the hormones, including thyroid, adrenal, hormone, sex hormone, all of those things. You can always do adaptogens, always. On every patient, the adaptogens, stabilize homeostasis. That's what we're going for. Nutrient and brain support as usual, and of course, evaluate the liver and detoxification. Okay, hormone cases, just a few hormone cases. We have a 30-year-old patient with PMS, heavy periods, breast tenderness, high stress, and she happens to come to me on DHEA supplementation. So basically what we're looking at here is on the upper left blue arrow, her progesterones are okay. That means she's ovulating. She's making progesterone. Underneath that, you will see her DHEA, two of her DHEA markers. One starts with an E, ethyl-calanolone, and androsterone. They're on the red because why? She's on DHEA. She's probably on too much. Easy fix, cut the dose. On the right side, you'll see her estrogens. Her estrone and estradiol are in the red. Even though she's ovulating and making progesterone, she's way more estrogen dominant. She's still obviously having PMS, heavy periods, breast tenderness because she makes more estrogen than she does progesterone. The easy fix is to look down below it at her phase 1 and her phase 2 detox. Her phase 1 detox is sluggish. The very bottom blue arrow on the right points to her 2-OH, her 2-hydroxy, and it's in the range, but it's not nearly high enough from what I want it to be. I want it to be up super high to keep up with her high E1 and her E2. This woman needs DIM, brassica family, indole-3-carbinol. She needs all the phase 1 support. Her phase 2, her 2-methoxy looks fine. She doesn't have a problem there. Her COMT probably works fine. So she just needs the phase 1 support. That will help greatly with all the symptoms. Plus, I'll cut her DHEA. Yeah.
Sorry, can you just get back to that slide?
Yeah.
Because I always looked at the, the pies here, and because the pie was very much in the green and where it should be. So you're saying that because they're really high estrogens here, it's like that river again. So there's a lot coming down. So that 2-OH there should be more towards the
Right-hand star.
Okay.
Yes.
So that dial at the bottom should be in alignment really with the levels of the top estrogens. Can you kind of say that? Or
I
not?
do, yeah, I do. Especially do the E1 and E2 arrows should they line up to the 2-OH, the 2-hydroxy arrow line up with the E1 and the E2 dials? I think so, yes. Especially when the E1 and the E2 are high.
Okay.
Then I want the 2-hydroxy high also. I want phase 1 as fast as what's in circulation.
Brilliant. Thank
Yeah,
you.
absolutely, to reduce risk and symptoms in her case.
Thanks.
This is the opposite kind of patient. This is a 45-year-old perimenopausal patient. She's irregular cycles, hot flashes, night sweats, brain fog, all the classic stuff. It really doesn't matter what arrow you look at, everything's low. Everything's in the yellow. This poor thing, she is really depleted. And some of her stuff is pointing like at the low end of the menopausal range, and that's why she's feeling so poorly. She needs to be higher in the menopausal range. So what do I do for her? Well, we have some treatment suggestions. What do you do about low progesterone? If she's a woman who is still cycling, address the cause. Work on her with PCOS, work on if it's her thyroid, work on stress. If she's underweight, overtraining, poor diet, just go right for the cause. If she's not absorbing, address the gut. Certain herbs that can be really helpful are things like chaste tree berry, otherwise known as Vitex. How many of you are familiar with chaste tree or Vitex? It's like the greatest female health adaptogen ever. It also helps lower prolactin. Prolactin is your prolactation hormone in the brain, not due to a tumor, but if you have mild elevated prolactin for other reasons, usually it's hormone imbalance, it can be quite helpful. When I do chaste tree, I do it every day in the morning, because I want to prep the first half of the cycle for the second half of the cycle and then repeat again. So that's when I use it. Now, some people will say, well, you shouldn't use chaste tree or Vitex if you have PCOS. I still do. I still use it with PCOS. If she has a negative response, and I warn her ahead of time, then she can stop. But I find most of the cases of PCOS actually do quite well, in my experience, with chaste tree. I don't use chaste tree on menopausal women because she's not going to ovulate. So why am I trying to force her to ovulate with this supplement? Not many of you use glandulars, but for those of you who do or have access, I do use ovarian glandulars to help improve ovulation. I'll also use brain glandulars, but you can absolutely use the herbs like maca and cordyceps that we talked about earlier to help with hypothalamic and pituitary communication. B6 is a great one, like we've talked about. B6 helps pretty much everything, but ovulation is a great one that it helps. It regulates FSH and LH, which I really, really like. And the dose is there, 20 to 50 milligrams. I also use EPO, evening primrose oil, and I do use borage oil. I had a fertility herbalist tell me that you have to be careful with evening primrose oil because it might cause mild contractions. And if she's working to get pregnant and implantation, you don't want to disrupt implantation, then you should just use it in the follicular phase. If she's not looking to get pregnant, you're just trying to get her ovulating, then I do use it every day all through her cycle. Which also leads, if you have a woman you're working with who's trying to get pregnant, keep in mind with implantation, when implantation happens and it burrows into the wall of the uterus, that it releases these specific cytokines, and those cytokines tell the brain, I'm pregnant, and everything changes. Now, cytokines are inflammatory, so if you're taking an anti-inflammatory, like over-the-counter ibuprofen or something like that, you can nip those cytokines in the bud, and then you may lose the baby just because, or not even the baby, but like you'll lose implantation just by doing that. So I tell my fertility patients, hey, at ovulation, I don't want you taking anything that's going to reduce those cytokines. I don't care how bad your headache is, suck it up. We're trying to get you pregnant. So just be aware that can be a real problem. What do I do for estrogen if it's low? Again, address the cause. We have that huge list way back in the beginning of the slide. Look at those and see what's up. I do think chaste tree, again, specifically it helps progesterone and the HPO communication. But if you help HPO, you will help estrogen just by default. Glandulars, I already said, maca, cordyceps, DHEA for those who use it or get it, or if they come in on it, can be helpful. And then here are the herbs that are really great for supporting estrogen, which many of you are probably quite familiar with. I will say they're called estrogenic herbs. They're very, very mild. So what they're supposed to do is they're to bind to the estrogen receptor to allow your own free estrogen to float around and be higher levels. Unfortunately, I don't see that. Now that I work for a lab, I have lots and lots and lots of clients that are on some of these herbs, and while their symptoms get better, their actual estrogen levels don't rise. Now, having said that, I do see a rise in estrogen with the bottom herb, shatavari, and with maca. I will see a rise of estrogen with those two herbs. But I don't really see it so much black cohosh, dong quai, red clover, waponticum, but I do see symptom improvement. Yes?
Black cohosh works more on FSH and LH. It's more through the pituitary than specifically on estrogen.
On the estrogen. So she's saying the black cohosh works specifically more on the FSH and LH. So from the pituitary, not so much on the estrogen receptors.
And then it influences the ovaries, so it's particularly won't work if you've got somebody who's had a surgical menopause.
Oh, surgical, right. Oh, right, yeah. Oh, I actually don't find, I don't know about you guys, I don't find black cohosh actually works that much, period. I have a tough time with it.
I find it works really well as a liquid.
Oh, as a liquid. You find it works really well as a liquid.
It's virtually useless.
Yeah, tablet, yeah, I would agree. Yeah, tablets are tough. Androgens, okay. Here's the thing, this is just your friendly reminder once again, when it comes to androgens, remember the ovaries produce some of them, the adrenals produce some of them, and the fat produces some of them. So if you have a patient with an androgen issue, too low or too high, you have to look in a lot of different places. Don't just assume it's one gland. So keep this in mind. PCOS. It seems to fall on a spectrum. You get these patients that come in and you're like, well, you're kind of PCOS-ious. Maybe, I don't know, you sort of fit the picture. Sometimes it involves insulin. Sometimes it's an adrenal problem. And we know that because if we go back 2 slides, you'll see on the adrenals, 25% of the testosterone, 50% of the androstenedione, 80% of the DHEA, and 100% of the DHEAS are made there. So the usual story is, right, they haven't gotten their cycle, or maybe they got their cycle and it's really irregular as a teenager, and as a result, their practitioner puts them on the birth control pill, because that's what every teenage girl needs to be on, is the birth control pill. It fixes everything. Now she starts to get acne, so she goes on medication for acne. She's starting to lose her hair. She's starting to gain weight. She's having all these problems, and now she's in her 20s or her 30s, and she shows up at your doorstep on all these medications with all these symptoms that have never been dealt with, and what is her primary goal? She wants to get pregnant. Get her pregnant. And she has this whole mess of a history behind her. This is the typical presentation. Androgen excess symptoms, we talk about hirsutism. When I say hirsutism, this is the hair growth in places you don't want. This is the upper lip, around the nipple, down the belly. Now, on the chin. With hirsutism, I don't mean the one straight chin hair that all women seem to get. That doesn't count. I mean like actual excess hair growth. Male pattern baldness, acne. Same with acne. I don't mean the one spot that like shows up with every cycle on the side of your nose. I mean like acne. Think that androgenic acne where it's here, where it's very testosterone related. Anger, irritation, mood swings, like my patient who was put on way too much DHEA. Ovulatory issues. She doesn't get a cycle. She's not ovulating. She's not making progesterone. She can't get pregnant. Lastly is this fancy word, polycystic ovary morphology, where she gets all the cysts on the ovaries. The cool thing is, it's 2 out of 3 is the diagnosis. So she doesn't have to have cysts on the ovary. This makes PCOS a really terrible name for the condition, because you can have androgen excess and ovulatory dysfunction and have just normal ovaries, no cysts. Or you can have cysts and androgen excess and no ovulatory issues. So it's a terrible name. That's what I say. Is obesity part of the diagnosis? Absolutely not. Only 30 to 75% of women are obese, which means you can have women with normal weight. If they're normal weight, it's probably not insulin-based. It's probably adrenal-based, although you can have a combination of the two. If it's adrenal-based, this is the cascade of events that happen. Insulin resistance occurs. That can result in obesity. You get all this excess insulin floating around. That causes a decrease in the sex hormone binding globulin. And remember, when the sex hormone binding globulin goes down, that's the bus that binds up testosterone. Now it's down. Testosterone is free to play, so it goes way up. On top of that, in your ovary, this lining or this layer of cells called the theca cells starts to make excess testosterone, and as a result, you get this stop of antral development. You don't ovulate. You don't have a dominant follicle that's chosen, and that's why you get all these crazy little cysts, because it's all these, like, everything stops, comes to a screeching halt. You don't make an egg, and now you look like multiple cysts on the ovaries. And you don't ovulate, therefore you don't make progesterone. However, as you know, it could be adrenal, which we're going to talk about in a case. These are other commonly run labs when you have a PCOS patient. Of course, if you suspect the insulin part, check the insulin part. Check their blood sugar, their glucose. Check their thyroid. If they're having problems getting pregnant, if they're not ovulating, they're skipping cycles, it could absolutely be hypothyroid. It's one of the trademarks of it. Check their prolactin. So prolactin comes out when a woman is breastfeeding in big amounts, but it comes out in little amounts when she has too much estrogen, when she's under too much stress, and when she has hypothyroid. So when she has a little amount of prolactin, more than the normal, the brain is like, what are you doing? Are we breastfeeding? Are we not breastfeeding? I'm not really sure what's happening, and it will throw off her cycle. So check her prolactin levels. Check her FSH and LH. 17-hydroxyprogesterone is what we use to diagnose something called congenital adrenal hyperplasia. It looks very much like PCOS. It's not that common, but I've had 2 come through the lab this year. Actually, both came through Florida. Don't go to Florida. Apparently you get congenital adrenal hyperplasia. She's looking to get pregnant, you can check anti-Mullerian hormones. You can see what's going on there, along with FSH. And lastly, maybe refer her for a pelvic ultrasound if it's warranted. This is my case. I had a married mother of 2 come in to see me. She's extremely stressed out. She's in a PhD program. Her cycles had become irregular in the last 6 months, and she was diagnosed with PCOS. She's 33. Her cycles just became irregular in the last 6 months. Does that sound like PCOS? No, the classic story is young, it's teens. She's 33. She's noticing acne and facial hair that's increasing, no change in weight, and she's normal weight, so I'm not suspecting insulin. But she has a lot of gut inflammation. Another practitioner in town had diagnosed her with SIBO. I ran her hormone testing, and yes, in the red circle, her progesterone's quite low. Makes sense. She's irregular cycles, she's not ovulating, so she's not making progesterone. That's one of the diagnoses. Her estrogens are high. One of them's high, one of them's borderline high. So she's borderline estrogen dominant. And she has high androgens and the symptoms to go with it. Some acne, facial hair. So just on this alone, just looking at the paperwork, total PCOS. She's 2 out of 3. But I was suspicious, Kat was suspicious. So I ran her adrenals. And it turns out she's making tons of total cortisol and tons of free cortisol. And I was like, okay, hold on. If the adrenal glands make a lot of your androgens, and when you're really stressed out, it can completely throw off your cycle, is this really PCOS? So what do you do? Where do you start? And like I said, is this really PCOS? Here's how you treat a PCOS patient. So I have it all written down. You don't even have to take notes. You're going to address the cause. You're going to focus on diet and lifestyle. You're going to address her blood sugar and insulin if warranted. You're going to improve her cortisol levels, you're going to restore ovulation, and you're going to reduce her androgenic symptoms. So, what do you do about diet and lifestyle? You guys know what to do about her diet and lifestyle. I'm not going to touch on that, but when you need a little extra help, you need some supplements to help you just like get her moving in the right direction as you're making all these lifestyle changes for her. These are some really good ones to get going. And the very first one I recommend a lot is berberine, because berberine in the research is shown to be as effective as the diabetic medication metformin or glucophage. And the dose is there. TID is 3 times a day, 500 milligrams 3 times a day. I give it with meals.
Can they take it with metformin?
They can, but usually they have to lower their metformin dose. So I'll use it to wean them off metformin. Let me say that. I will use it. I can prescribe. Naturopathic physicians have prescriptive rights. And so I will use metformin and berberine at the same time, but go up on one and down on the other and flip over. Yeah. Just have them watch their sugars. Or monitor their sugars. Stress, I feel like we've talked about a lot. You guys have lots of slides on what herbs to choose and what nutrients to choose. Here, I didn't leave it out. Look at me. Yay me. This is the calming cortisol herb part. So these are your phosphatidylserine with dose, your holy basils with dose, magnolia, your skullcap, your theanines with dose. So to help you, this is for high cortisol. High cortisol. If they have high cortisol, these are where you go look for. So you can do these plus adaptogens. If they have low cortisol, don't use these. These will just push them even lower, and then they will hate you. They will be tired. If you want to improve ovulation, we've already had that page, but just as a little reminder here, herbs, nutrients that can be helpful, oils, and for those of you who can prescribe or they have access to progesterone or come into you on progesterone, you can do it. And progesterone, if you're trying to get her pregnant or trying to get her ovulating, you tend to do progesterone in the second half of her cycle. Progesterone can suppress ovulation because the brain goes, oh, I already have progesterone, why would I ovulate? So you do it after ovulation. You want to reduce the androgenic symptoms. You want to reduce her insulin and her cortisol causes. Spearmint tea, if this is a research paper, spearmint tea is pretty anti-androgenic. Unfortunately, they did not look at peppermint. I don't know if peppermint's the same. Spearmint's what they looked at. And then these are what are called 5-alpha reductase blockers: saw palmetto, zinc, stinging nettle, pygeum, and reishi mushroom. These are basically the things we use for men who have enlarged prostate and get up often to urinate. Funny enough, if you're into supplements, a lot of these have the name prostate something, prostate health, prostate factors, prostate this, prostate that. So when you give it to a woman, their partner is usually like, really? This is scary. I'm like, I know, I just need the herbs inside. So how did I treat that patient? She was under extremely high stress. She had a gut infection. I started there. I think all of that was driving up her cortisol. It was increasing her adrenal androgens. It was throwing off her cycle and causing her symptoms. So I focused on the gut infection, reduced your stress. I did add in some taste tree because I just love it, and I think it's a great HPO adaptogen. And in 3 months, her periods resumed to normal. She didn't have PCOS. She had a PhD program with 2 little kids. That'll screw up a lot of people. So that's what I did. So these are your take-home messages. Last slide. The HPA axis starts in the brain, guys. Think macroscopic. Don't focus in right on the tiny little adrenals. Stress is cumulative. Take care of yourself. You guys, you take care of yourself as practitioners. Practitioner, heal thyself. Hormone imbalance can happen at any age. Please, please, please keep that in mind. Very frustrating for me are when patients come in and they say, I'm 23 and I have all these symptoms and my GP told me I'm too young to have these symptoms. I'm like, no, you can have these symptoms at any age. As we know, the world is sick and it's toxic and it's affecting people younger and younger. Remember to look at all levels of estrogen metabolism. You want to look at the whole bathtub, how much water is coming in, and is the drain draining appropriately. And lastly, PCOS might actually be a problem with the overactive HPA axis. So know if you're dealing with insulin-based or adrenal-based, or sometimes it's a combination of both. And that's it. You guys have been great. Nobody fell asleep. I'm so proud. Sorry, that was a little longer than 45 minutes.
Do we have any questions that haven't been answered already?
I'm going to hang around at the end too, so if you have questions you want to just ask me, you can come up at the end. We'll turn the recording off.
Here we go.
Michelle.
Sorry. Just on that PCOS case with the testosterone being higher and giving things like palmetto,
Mm-hmm.
how long is it safe to give that for?
It's actually really safe. I'll use the 5-alpha blocker, salt, palmetto, whatnot. I'll use them 3 months, 6 months, 9 months, however I need to sort of drive it the other direction while I'm working on the cause. Yeah.
And generally, how long do you see those shifting? Because obviously with DIM, the shift is very, very quick.
Very quick, yeah.
Weeks. But with those
Longer. The shift in the 5-alpha from the high testosterone 5-alpha part over to the less reactive beta part is more like months.
Okay.
Yeah, working for the lab and now seeing repeat testing, I can say, oh, okay, this is taking much longer than DIM. Yeah, not weeks, but months. And it also depends how fast they make changes in their life too. If they're changing their diet, if they're getting rid of inflammation, if they're getting their blood sugar under control, or if they're not. I can see that too.
Yeah, so if the Dutch test showed that somebody had low melatonin,
Yes.
what would you do? How would you support that?
You sleep hygiene stuff. So if one, I look at their cortisol. So if cortisol is high through the night, then cortisol is a bully and it will push melatonin down. And 2, I look to see what they do before bed. That might be suppressing melatonin. Bright lights, on their phones, they're all wound up, they're so busy putting their kids to bed, that's what I work for.
You wouldn't support it with
Supplements.
supplements?
If I do supplements, I can get melatonin. Sometimes I will do melatonin as a Band-Aid while I'm working on the other stuff. Melatonin comes from serotonin. Sometimes I will do, and if they're depressed and their melatonin is low, sometimes I will do 5-HTP and support serotonin pathways instead. Yes. Yeah, absolutely.
Would you prescribe melatonin itself as well?
So in the States, melatonin's over the counter. Yeah. So you can just get it. Yeah, you can go anywhere, everybody, anywhere. It's not even like kind of weird to get it, like it's everywhere. But yes, you can prescribe melatonin, absolutely. Now when I prescribe or if I give melatonin, I do low dose. I do 3 milligrams or less, typically. Yeah. Yeah.
Other than your reducing your exposure to blue lights at night, do you have any strategies which are your kind of go-to habits to induce a good sleep?
Habits to induce a good sleep. Yeah, that's a...
Other than the light, other than the blue light.
Well, you can buy the glasses, you can buy the orange glasses, and you can buy the, are they red light bulbs or orange light bulbs? They're specific for sleep, where you can take out all your white light in your room, in your bedroom, and use these special red lights instead. So if you don't buy the glasses, you can actually create a non-blue environment in your bedroom. And then I have the night, what's that called? Night
shift.
There you go. Night shift on my iPhone. Which I find night shift is helpful, but when the glasses are just next level. They're even more powerful. I don't have the light bulbs in my bedroom. I'm not there yet. I'm not that nerdy about it. But I have colleagues that do, that have bought the special light bulbs. But then, you know, my concern for that, though, the red, orange light bulbs, I get sleep is critical, but so is waking up. So if you go to wake up in the morning, now people will buy the bright lights, the daylight light bulbs, and full spectrum light bulbs is what they're called. So I'm like, okay, do you have like the orange on this side of the room and the full spectrum on this side of the room, and you only turn these lights on in the morning and these lights on at night? It's very confusing. So I just use the glasses when it comes for blue light stuff. Yeah. And I know there are apps, if you have iPhone, I know there are apps to do it, but they don't work as effective as I think they should. Any other questions?
I do have another question, sorry.
Yes, Michelle.
On the phase 1, you know how the gym works very, very quickly within like 2 weeks?
Yes.
Some people can't afford to retest that quickly.
Yeah.
So, what's my question? If people are taking the DIM,
I go by symptoms.
and we're working, and the symptoms have improved,
Yeah.
we stop the DIM, but then can it come back the next month again, and then the DIM again, and we have to keep cycling it? How do you work that? How
Yeah.
do you...
So the question is, if they're on DIM but they can't afford to retest in 2 weeks to see if it's working, so they go by symptoms and they go off of the DIM. Do I find myself cycling them on and off of DIM? I tend to do DIM longer than 2 weeks. I usually do DIM for 3 full cycles before I make the decision to cut the dose or take them off completely. So I give them, and the reason I do 3 cycles in women a lot for a lot of my treatments. Your ovaries are sisters, not twins. And so righty and lefty may not do the same thing. And so by 3 cycles, I can get an idea maybe of like what righty and lefty are doing. And sometimes you have an evil sister and a nice sister. And sometimes they're both evil and sometimes they're both nice. And when I tell patients this, they're like, yeah, I have months that are evil. I'm like, yeah, it's the evil side. So if righty goes in June and lefty goes in July, and then lefty goes again in August, like that, I'm trying to catch at least both ovaries once to get the herbal or nutrient effect into them and the HPO access. So I do 3 cycles and then I assess from there. I do find sometimes they, depending on diet and lifestyle and stress and inflammation, they have to go back on DIM. If they've fallen off the diet bandwagon, if they don't eat as many veggies, if they're traveling quite a bit, then I will say,
And do you
hey,
have
back on DIM.
cases where they're on it long term? Because they come off it and their symptoms, they keep coming back just because
Genetics.
stressful and genetics.
I do. Yeah, I do have cases where I have them on DIM long term. The flip side to that, though, be careful. DIM will lower E1 and E2 out of circulation. So if you have a woman who already has borderline low estrogen issues, or you have her on DIM or indole-free carbinol, and over time she says, well, now I have hot flushes, you've just pulled her estrogens too low, stop the DIM and the indole-free carbinol. It's done its job. Now it's gone from high through the normal range and too low. It's potent stuff. Yeah.
Thank you very much.
Excellent.
Well, brilliant.
Thank you to Regenerus. I appreciate having me come out here.
Well, actually, you stimulated a couple of points I thought were relevant to bring up, so if you don't mind joining for a second. He says, anything about glasses and needing to read? Right, a couple of very valid points to add, not take away. Recordings will be available from Monday, first and foremost. Secondly, some comments about the handout presentations earlier on this morning. Actually, they've already been resent to you, so you have a large scale one that you can either download before you leave here today, so you can read on the way back if you're on the metro or on the bus, not in the car, obviously. So a couple of other things, obviously you mentioned about stool testing, comp testing, viruses, Lyme, all of which are available from Regenerus, including reverse T3, thyroid antibodies, SIBO testing. So to complement everything that Precision and Dutch can do, we can support you with all of that. T3 uptake as well is with that. Of course, we have an in-house team, so when you do struggle, if you can't get up or stay up late enough in the evening to speak to the team in the States, then obviously we've got a local team here to support you as well. Laura is obviously at the back, has been accompanying Carrie for the last few days. And I think that is all I needed to throw into the mix, but needless to say, thank you very much indeed for joining us today for a great afternoon, and if I can ask all of your hands together, thank you very much.
Thank you.